بسم الله الرحمن الرحيم. هنبدأ إن شاء الله البلانري سيشن في اليوم الثاني من المؤتمر. يشرفني إن شاء الله يكون معانا النهارده على التشير بيرسونز أستاذ الدكتور محمد إنديل، رئيس قسم النساء السابق بجامعة المنوفية، أستاذ الدكتورة أميمة إدريس، أستاذ أمراض النساء جامعة القاهرة، أستاذ الدكتور ضياء عجلان، أستاذ قسم النساء والولادة في جامعة طنطا، وصديقي وزميلي الدكتور إيهاب سراج، أستاذ قسم النساء بجامعة عين شمس. The first session will be model for entrustable professional activities in obstetric and gynecology rotation model. بوصف الأستاذ الدكتور محمود يوسف.
السلام عليكم. اوكي. طبعا I would thank Professor Hatem and Professor Amr Husseini to allow me to present this most important item for the teaching of the student and the internship. Model for entrustable professional activities in obstetric and gynecology, rotation of 5+2 program. 5+2 program is based on competence-based learning, while 2 program is based on application of entrustable professional activities. Competence-based learning, application of skills and knowledge. Application of skill and knowledge that enable people to successfully perform their work. Learner will perform individual jobs, responsibilities, roles, and capabilities. Competence say how we can be certain that they know it and able to perform. There may be more than one measurable outcome defined for a given competence. Teachers should think concertedly about what students ought to be able to do at the conclusion of your course that they could not do at the start of the course. The philosophy of competence-based learning: the graduate will be a member of the healthcare system, will be a member in healthcare team, will share in patient care, will ask for consultation and also refer the patient according to the management plan, will be professional in work and follow the code of ethics. The graduate will share in the activity of the research. 5 years is competence-based medical education. The first main competence area, the graduate as a healthcare provider, he will learn how to take history taking, assessment of mental state, and how to deal with emergency and call situations. Clinical examination, differential diagnosis, order investigation, interpretation of the investigation, diagnostic procedures, clinical decision-making, plan of management, pain management, evidence-based medicine, intervention procedures, and he will take in consideration in the management plan the patient and family involvement, and will at the end will take the consent. The second competence area is a graduate as a health promoter. He will know the health determinant, nutrition and physical activity, disease prevention program and education, infection control, epidemiology of disease and measures to reduce and prevention, risk factors, abuse and neglect, care for pregnant women, newborns, infants, adolescents, and as the earliest, environmental and occupational hazard. The third competency is a graduate as a professional behavior and relationship in all aspects of practice, demonstrating honesty, integrity, commitment, compassion, respect, national code of ethics and laws regulating practice, patient respect, equality, culture and beliefs, confidentiality and privacy of the patient's information. He will realize his errors and conflicts of practice, limitations, and reporting. The fourth competence area is a graduate as a scholar and scientist. He will be able to build clinical practice and interpretation based on pathophysiology, anatomy, biochemistry, prescribe medication based on pharmacology, scientific basis and interpretation of the result of common diagnostic modalities, basic science for future gene therapy and artificial intelligence. Performing general procedures as a physician, demonstrate preparation and reliable technique, applies knowledge of key issues, seeks appropriate help, mitigate complications, consistently use universal precautions and aseptic technique, provides complete timely documentation, paper and digital. The fifth competence area, the graduate as a member of the health team and part of the healthcare system. You will know the role of each member in the healthcare team, respect, resolve conflicts, he knows his responsibilities and healthcare quality, his limitations, hand over, referral and consultation, and will be a leadership. The last competence is the graduate as lifelong learner and researcher. Self-evaluation and improvement, continuous medical education, time management, research, identify knowledge gaps in clinical and generates focused questions. Research, share statistical analysis, precise presentation for professional and lay audience. The 2 years of the internship are based on untrustable professional activities for medical interns. The house officer has to report what I do right and what needs more development and plan for further development. And here there are 20 points. These are the entrustable professional activities. So it is very important to know what are the standards of entrustable professional activity in order to help this medical education to fulfill this report at least. The first entrustable professional activity, 1A, obtain history adapted to the patient's clinical situations. The type of history either is full history or focused history or follow-up history. Character of history, it should be complete, accurate, and organized, and he should take additional information if the patient has a problem to give the full information. Adaptation of communication skills, eye contact, check patient's word, respond to the patient's verbal cues, and respond to non-verbal cues and emotions. Assure patient is understanding doctor's word. He should give provisional diagnosis based on differential diagnosis, clinical reasoning, and the secondary data for clinical reasoning. The AP1B, perform a physical examination adapted to the patient's clinical situation. The perform physical examination adapted to the clinical situation, character of clinical findings should be accurate, logical sequence, identify normal findings and identify the abnormal findings. The diagnosis should be based on considered differential diagnosis, determine the most possible diagnosis, clinical reasoning for the diagnosis, and what is next. The second entrustable professional activity, he has to formulate and justify and prioritize differential diagnosis. The differential diagnosis is based on the following items, either history information and examination findings, investigation levels, and follow-up observation. The steps for differential diagnosis, filtration to each diagnosis, organize data that supports the diagnosis, clinical reasoning to support the diagnosis. He should have the ability to answer questions from team, patient, and family, incorporate team suggestions and team's answer to the questions. Update diagnosis is based on new history information, new clinical findings, or new result of investigation, or suggested questions of possibility. The third entrustable professional activity, formulate an initial plan of investigation based on the diagnosis or hypothesis. Explain the need for the investigation, consider the cost of the investigation, explain how results will influence the diagnosis, and explain how results will influence an evaluation, interpreting the result of the investigation. A highly sensitive test will correctly identify a higher proportion of patients with a given disease, true positive. A highly specific test will correctly identify a high proportion of those do not have the disease that true negative. The fourth one, all over the world they use the order of investigation and interpretation as one item, but here in Egypt we make them two items. The interpretation incorporates sensitivity and specificity and prevalence in recommending the patient to interrupt the test, explain how the result will influence diagnosis and evaluation, seeks help for interpretation of the test beyond the scope of knowledge. We have طبعا gynecology, screening for gestational diabetes, cancer cervix screening, cancer breast screening. The fifth, entrustable professional activity, recognize the patient requiring urgent or emergent care, provide initial management, and seek help. But what is the type of critical care? It is cardiac arrest, respiratory distress, or shock. The management of critical cases, the behavior during management of critical cases. He should have evaluation of the critical space properly, communication behavior with health team, leadership during management of emergency, follow up institutional regulations, and monitor the response of the critical case. He should know how to do basal life support, advanced basal life support, management of hypoxia, airway obstruction, diagnosis of type of airway obstruction, what is the criteria of airway obstruction, and management of airway obstruction and management of shock. The sixth, entrustable professional activity, formulate, communicate, and implement management plans. The management plans is based on incorporating teams sharing a management plan and the components of the management plan, and he has to document the management plan and medication prescribed. When he is going to prescribe any medical prescription, he should fulfill the following items. He should recognize the illness history and diagnosis, consider whether the prescription is appropriate or not, choose the appropriate medication, where the appropriate, clarify the medication with the senior medical staff, clarify the name and dose and the frequency and duration of medication, consider drug-drug interactions or allergy, check whether to proceed in case of drug allergies or not, check whether to proceed in case of drug-drug interaction, and provide instructions on adverse effects, elicit any patient concern about the benefit of the risk. Time professional activity number 7, perform general procedures of physicians. Perform general procedures. He has the knowledge about the procedure, demonstrate patient-centered skills while performing the procedure, steps of performing the procedure, behavior during performing the procedures, behavior with teams members, and he has the end to document what is the procedure. He has, these are the following basic procedures. He should fulfill them completely at the end of the 2 years. Vein function guidance, IV cannulation, prepare and administer IV medications, injections and fluid, arterial punctures in the adult, blood cultures, IV infusion including prescription of fluids, IV infusion of blood and blood products, injection of local anesthetic to skin, subcutaneous injections, intramuscular injection, perform and interpret ECG, perform and interpret the peak flow, urethral catheterization for the male and urethral catheterization for the female, and airway care including simple adjuncts. The entrustable professional activity, he is going to present oral and written reports that document a clinical encounter. And the other countries, they make this entrustable professional activity into 2 items. The oral is 1 item and the written is 1 item. He should have the capability to present oral and written reports that document a clinical encounter, steps for preparation of the presentation, presents personally verified and accurate information even when sensitive, filter, synthesize, and prioritize information into a concise and well-organized presentation. Integrates pertinent positive and negative to support hypotheses, provides sound arguments to support a plan, tailors length and complexity of presentation to situation and receives of the information. Points need clarification. It's very important to be able to make presentation easily accessible for the patient and family. The interest of professional activity number 9, he should provide and receive the handover in the transition of the care. Awareness of the situation of handover components, present verbal handover that is precise, relevant, and succinct, avoids interruption and distraction, manage time effectively, highlights any severity accurately, provides complete action plans and appropriate contingency plans. Behavior during providing the handover to the patient. He should listen actively, provide and solicit feedback regularly. Communication in difficult situations. Awareness of difficult situations, steps of communication in difficult situations. And trustable professional activity number 11, educate patients on disease management, health promotion, and prevention medicine. Awareness of situation of health promotion, identify risk factors, modification, incorporate healthcare team, coordinate with other healthcare team members to ensure appropriate messaging to ensure consistent messaging. Trustable professional activity, obtain informed consent and procedures. Trustable professional activity, he has to apply infection control and other relevant safety measures in different clinical situations, hand hygiene, environmental cleaning, safe processing of reusable equipment and instruments, respiratory hygiene and cough etiquette, aseptic non-touch technique, appropriate use of antimicrobial including antibiotics. Trustable professional activity number 14, collaborate as a member of the team and profession.
Time, but 1 minute more. 1 minute more, the time is over.
Management time and share in writing medical legal reports and apply evidence-based steps including formulation of clinical questions and retrieving available evidence of communication. The entrustable professional activity is 5 levels. Number 1, observation without capability to do under showing, do with under care, observations, doing alone, and doing and train other people. So usually we are going to concentrate either to show them and try to do or to do under observations. He will, because of the large numbers, we cannot approach to do alone or to be trained. Take home message, the implementation of entrustable professional activities for the medical intern during the 2 years program needs the effort of all the clinical staff for maintaining proper health service. Thank you.
Thank you. Thank you, Professor Mahmoud, for this informative presentation. Now it's my pleasure to invite the next speaker, Professor Tamer Borg. He will address a different eye on repeated implantation failure. Does it really exist? Professor Borg. Please, for all speakers, please stick to your allocated time. Every speaker, please stick to your allocated time.
Thank you again. I'm always honored to be part of the ASOGIC, and I'm always honored to present my presentation in front of an eminent speakers like yourself. So to jump directly into the subject, the topic today is about repeated implantation failure. Does this condition actually exist or not? So when you know about certain disease and you start to figure out, does it really exist or is it a myth or is it just a fairy tale? So it reminds you of the fairy tales like Alice in the Wonderland. You know, Alice was looking into a small hole in the garden and she figured out that this is just a hole. And when she entered the hole, she was amazed of the many wonders she had seen. But the problem is that all through the novel, you are not aware whether this land does really exist or is just a statistical myth. So for the coming moments, allow me to be your guide in the wonderland of implantation failure. And together we will try to find out whether does this land actually exist or not. So one of the most difficult tasks I faced when preparing this presentation is to find the definition for repeated implantation failure. Actually, the definition is very rare to be found. The only accepted definition by the ISHRI is that the patient keep on failing to get pregnant after transferring of 3 different embryos in 3 different occasions. There is a lot of controversy about this definition. Who said that these 3 embryos are good? And when do you say that they are good? Day 1, day 2, day 5? And what do you consider failure of pregnancy? Do you consider the chemical pregnancy a pregnancy or not? So the best things is the most important, the weird question was why 3 embryos? Why not 4? Why not 2? So it was based on a statistical model. You know, the bell of normal distribution, we say that if you manage to achieve what 95% of the population can achieve, then you are normal. But if you fail to achieve what 95% of the population can achieve, then you should be considered as abnormal. So, in the work of Professor de Ziegler, he found that 95% of the IVF population will get pregnant if they manage to transfer 3 euploid embryos. Euploids means that they are tested. They have been examined for chromosomal abnormality. The problem is that most of the IVF centers do not do routine examination for the embryos. So how do I reach these 3 euploid embryos? If you look at these numbers, so if I'm speaking about a woman that is less than 35 years old age, it's easy for me to reach this diagnosis because if I transferred only 4 embryos to this lady and she did not get pregnant, then maybe she is having a repeated implantation failure. But what truly actually happened is that most of our population lies in the last 3 lines. And then you find that patients are defined as repeated implantation failure because they fail transfer of 3 embryos, while we actually need to transfer 7 or 13 embryos to get pregnant. So it's just like as if you are considering someone infertile because she did not get pregnant after 2 months of pregnancy. And you tell her, you have been married for 60 days and now you are not pregnant, you are infertility. She did not continue the chance that she should have. So unless you transfer this number of embryos, you cannot say that a certain female is having a repeated implantation failure. Because of this controversy, some very eminent speakers from both sides of the Atlantic Ocean gathered in Lugano 2022 to find out the possibility, does this condition actually exist or not. What does this work did? I don't want to complicate it for you. We make a very simple statistical model. We say we are going to assume that there is a disease X, which is causing women to repeatedly fail IVF. So if this disease X is not treated, these patients will keep on accumulating year after year after year. And then I should find that the results of IVF all over the world should keep on decreasing year after year after year because disease X is not being treated. But this is not the fact. The truth is that IVF success rate is increasing every year, which denies the possibility that a certain disease exists that prevent embryos from implantation. So that's why we reach the conclusion that if the disease X exists, it should not be present in more than 5% of the population. Okay, but what about all these theories and all these centers dealing with immunological treatment for repeated implantation failure? Okay. The best evidence we have about immunological treatment for repeated implantation failure came from only 2 meta-analyses. All the meta-analyses addressing immunological treatment for repeated implantation failure failed to find any role. Only 2 meta-analyses find a very minimum role, and if you look at the authors of both meta-analyses, you will understand what is the similarity between the 2 meta-analyses. They both came from the same country. In Egypt, we have a word when we describe something of extreme excellency, you say it's made in China. So both these meta-analyses were made in China. If you look at this meta-analysis, of course, I know some people are getting frustrated with these complicated images, but it's easy. If the intervention is crossing the middle line, this means it has no role. If the intervention is reaching the middle line, it means that it has no role. So even the meta-analysis that try to find the role for immunotherapy, we found no role for intralipid, we found no role for low molecular weight heparin, we found no role for colony stimulating factor, and the only 2 interventions we found the role for were injection of PRP and peripheral nuclear cells, because these 2 interventions, we didn't find enough studies to address them. So we had to rely on the available evidence, which was only 1 study in every intervention. Of course, you cannot draw evidence from 1 study. So what does the actual guidelines say? The ISHRI guidelines voted red for all these interventions. They say that all these immunological treatments is nonsense. Because ISHRI is heavily criticized. We are old, we are European, we are not up to date. The other side of the ocean, the Canadian societies agreed as well. I did not include the American Society recommendation because it was dating back to 2018. Yeah. But again, somebody is going to tell me all of the great achievement in science was heavily criticized. The greatest scientific achievement of all time, the discovery of the conquest of paradise. Now, the conquest of paradise, Christopher Columbus arrived in Spain in the 15th century with a very bizarre theory that was heavily rejected in his country, heavily rejected in France, heavily rejected in all over Europe. The theory was that if the world is spherical and I can travel to the west from Europe, I will reach Asia or China easier than I travel to the east. Of course, the theory ignored the very simple fact that there is a whole continent in the middle which he knows nothing about. It's the same as one immunological scientist said that if I'm having an embryo and it failed to implant an endometrium, and there is a killer in the room, there is cells called uterine natural killer cells, then definitely the killer is killing the embryo. Of course, again, they ignored one simple fact that uterine natural killer cells do not kill anybody. They are actually regulatory cells. And there is no resemblance whatsoever between uterine natural killer cells and peripheral natural killer cells which are measured in blood. It's just a common name, but they do not do the same function. Anyway, the theory of Columbus was accepted by only 1 queen, Isabella, Queen of Castilla, اسمها كده, Isabella ملكة قشتالة. If you look at this photo, I think it's in the museum in the Louvre. The Queen Isabella actually sold her gold to sponsor this theory. So how many Egyptian women has actually sold her gold to sponsor the theory of the immunological treatment? The rest of the story you all know. 2 months in the sea and the sailor says land, land. Columbus arrived in the Bahamas. He made no effort whatsoever to confirm what he discovered. He immediately declared that his theory is correct. He has found a new route to Asia by traveling to the west. He brought back weird individuals, which he called them the Red Indians, and he brought to himself gold, which is all that he wanted. Just exactly as most of the centers of IVF do not wait for patients after having a pregnancy test to confirm if this is a real pregnancy or is it just a chemical pregnancy. But you know what is very ironic about this story and what is sad? The 2 continents he discovered was never named after Christopher Columbus. 20 countries in the 2 continents he discovered, none of them are not even a capital bear his name. 52 states in the biggest country he discovered, none of them even bear the name. Actually, you don't find the name Columbus in America except in a very tiny village in Ohio. what is the reason for this extreme unfaithfulness? You know what? Because up to this moment, in October 2024, Columbus lies in his grave or in hell, wherever he is, believing that he was successful, that he has discovered a new road to Asia by traveling west. He knows nothing about Americas up to this moment. His diary said that he went back to his home country, he got blind, and he got sick by a rare disease that he thought he caught from traveling to Asia. Ironically, Columbus never set foot in Asia. He landed in the Bahamas, 7,000 kilometers away from India. So the man was so blind that he believed his own lie, and he continued to fulfill this dream, even though all scientists tell him this is impossible. But because wrongs cannot be right forever, or right cannot be wrong forever, it will take only 2 years for a real scientist, Amerigo Vespucci, to arrive to the conclusion that evidence-based medicine apply. That actually this land is not India, and to know what any 6-year-old child knows right now, it's impossible to travel from the West, from Europe, and reach India. Just like maybe 50 years from now, school students were going to wonder and say, do you recall that there was time that scientists were actually giving women immunotherapy to get them pregnant, and that actually patients were being receiving chemotherapy to get pregnant? It's the same story. So, I am going to be hearing experience from the audience. We have seen patients who have done IVF. We have failed with you. We have failed with Professor Abul Ghar. We have failed with Professor Muhammad Yahya. We have failed with all the eminent doctors. And then we went to the mysterious Dr. X, and he treated them with immunotherapy, and we got pregnant. So he is right, you are wrong. Now let me show you how this game is being played. For the coming few minutes, allow me to play the role of the devil's advocate. I will let you suspect anything that you have ever believed in your entire life. Okay. I made a plan to be the most successful IVF doctor in Egypt, and this plan depends upon declaration that I have invented a new secret medicine. This new secret medicine, it will cure any IVF failure. No patient is going to fail IVF from now. So I'll give you a clue about this secret medicine. It has been there since the beginning of time. In Egypt, it comes from Africa with extreme difficulty. Peoples have been killing themselves all over the world all through this time. Now, who can answer this puzzle? What can this medicine be? It's water. We are going to treat patients who failed IVF with water, tap water. Okay, SAR data says that if you have 3 failed IVF, this was in 2022, 20% of your patients are still going not to get pregnant. But if you did a 4th IVF, this number will drop to 10%. So this means that 50% of the patients are going to succeed the 4th IVF without doing anything. When we repeated the same analysis later on, this number increases to 60%. So if you treated patients who failed IVF once, twice, thrice, with the same treatment the 4th time, you will have a success rate between 50 and 60%. So if I announce to the world that I'm treating repeated implantation failure with water, I am going to present to the world every day 5 new miracles. 5 patients who failed IVF 3 times in the biggest centers of Egypt. They came to me. I treated them with water, intralipid, IVIG, anything that you hear about in the market, and I have a 50% success rate. Okay, now you are going to tell me this is impossible. ادوني 3 دقايق بس اخلص لكم الليله دي. Now you are going to tell me that it is impossible. You cannot treat repeated IVF failure by water. So Houdini was the greatest measure in all time. He says, what the eye sees, what the ear hears, the mind believes. So if people keep on seeing miracles, we see patients who failed IVF in the biggest centers, and then they got succeeded with whatever medicine, they will believe that this medicine is miracle, regardless of the fact that is not. Again, there is another problem that you cannot keep on using the same placebo all of the time. So we need to search for another placebo. In search of the evidence, we found this data. These data say that if you apply psychological therapy to women who have repeated IVF, you will actually have double the chance of success. So what happens is that a woman who has failed IVF once and twice and thrice goes to the mysterious doctor who is telling her, I am going to treat you with a medicine that nobody have ever heard about. It's very expensive, of course. It consumes a lot of money, but you be sure that you are not going to get abortion again, are not going to fail again. Do you think that these things will work? Yes, it actually works. I will be hearing that objections that it is impossible to treat a female condition by simply talking gently to the female. Well, believe me, you know nothing about La Femme. If I have known that secret 20 years ago, then all of my marriages would have been successful, which was not. So this was a fact that how a Russian peasant was able to control the Russian Empire. This is the power of illusion, convincing the woman that she is receiving a treatment which is miraculous, and this will allow her to get success. So in the combination now, if you offer the patients a miraculous drug, whatever its name, together with psychological therapy, you will find out that 60% of patients who have failed IVF in the biggest centers are now successful. This is not due to the miracle of intralipid. This is not due to the miracle of tacrolimus. This is not due to the miracle of anything. It is just statistical myth. Thank you. I'm sorry for the time.
Thank you, Dr. Tamer, very much for a very exciting lecture. Our next speaker, Dr. Adalia Abdel Mohsen. Dr. Adalia, she is a professor of medicine at Ain Shams University, and her talk about a very interesting talk for us, the antiphospholipid antibody syndrome in pregnancy and the revised effort for pregnancy morbidity.
Assalamu alaikum. أولا شكرا جزيلا. Thank you very much for inviting me for this great conference. أنا ابتديت أتعود بقى أجي عندكم كل سنة إن شاء الله. Today I am going to talk about the revised ACR American College criteria and ULAR criteria about the antiphospholipid syndrome. I will do a small introduction and I will enter into the classification criteria and I will summarize at the end. We all know that antiphospholipid syndrome is a systemic autoimmune disease characterized by arterial, venous, or microvascular thrombosis. It is also characterized by pregnancy morbidity and non-thrombotic manifestation in patients with persistent antiphospholipid antibodies. And we all know all the classification criteria for antiphospholipid is currently based on the Sapporo criteria and its Sydney revision. The Sapporo criteria, as we all know, depended on two main issues, thrombosis and plus antibodies. Thrombosis, either arterial or venous, or pregnancy morbidity, plus one of these antibodies, and it is a definite if present at least in one on the clinical criteria. These criteria were revised by Sydney revision criteria at 2006. They started to identify more details about the pregnancy morbidity, and they said as regard the pregnancy morbidity, either one or more deaths of normal fetus more than 10 weeks or one or more premature births at less than 34 weeks due to severe preeclampsia or placental insufficiency, and more than 3 consecutive abortions. And also they started to define they put some criteria that the antibodies should have medium to high titer above 40 in order to be considered inside the criteria. So since the introduction of the Sapporo criteria and its modification, advancement in our understanding, there is very many advancement as regard the antiphospholipid associated clinical manifestation, and also as regard the antibody and as regard the risk stratification for antiphospholipid patients. The Sapporo criteria have been criticized because it does not give a definite definition for APL positivity or macrovascular affection or pregnancy morbidity, and this results in the inclusion of heterogeneous group of antiphospholipid positive patients with different risk profile for researches. So I will now enter into the 2023 American College of Rheumatology and European League of Rheumatology. They united together to put a new classification criteria for antiphospholipid syndrome. The first step for this criteria, you should have entry criterion before applying any item. The entry criterion, you should have one or more documented clinical criterion plus one or more documented positive antiphospholipid test. The clinical criteria, as we will see later on, it will be one within one of 6 domains. And the antiphospholipid antibody criteria, as we said before, it should be moderate to high titer of antiphospholipid antibody. And also it should be present within 3 years of the thrombosis. يعني العيان جاله ستروك مثلا او مايكارديال انفاركشن، بعديها في خلال ال3 سنين اللي بعديها يكون الانتيفوسفوليبيد بوزيتيف عنده، والا ما تحسبش. لو اكتر من 3 سنين ما تحسبش كانتري كرايتيريا. And we don't, if absent, do not attempt to classify criteria. طب ايه الكلينيكال دومينز بقى اللي هي اتحطت جديده في الكرايتيريا؟ قلنا الكلينيكال دومينز قبل ما نتكلم عنها before we should not count the criteria if there is other explanation than the antiphospholipid syndrome, and within each domain you should count the high score. يعني كل دومين زي ما هنشوف كده مثلا في 3 4 ايتمز، واحد واخد 1، واحد واخد 3، واحد واخد 5. افرض عيان عنده اكتر من 1 في المربع بتاعنا ده، ما بنحسبش 1 زائد 5، لا بناخد اعلى سكور وخلاص. طب ايه الكلينيكال دومينز بتاعتنا؟ زي ما انتم شايفين بقوا كتيره قوي. دومين الماكروفاسكولار فينوس ثرومبوزيس، ماكروفاسكولار ارتيريال ثرومبوزيس، مايكروفاسكولار سسبكتد، مايكروفاسكولار استابليشد، obstetric، cardiac valve thickening، hematology. كل ده طبعا ما كانش موجود في الكرايتيريا القديمه. خلينا نمشي بشويش كده ستيب باي ستيب. اول دومين عندنا الماكروفاسكولار فينوس ثرومبو امبوليزم. قالوا لو عندنا عيان عنده فينوس ثرومبو امبوليزم بس معاه هاي ريسك بروفايل للفينوس ثرومبو امبوليزم، ده هياخد 1. يعني ايه هاي ريسك اوف بروفايل؟ هنقول بعد كده. لو العيان عنده ثرومبو امبوليزم without هاي ريسك بروفايل هياخد 3. طب ايه الهاي ريسك بروفايل؟ هاي ريسك بروفايل لو ميجر ده يعني عيان انا متوقعه انه يجي له ثرومبوزس، يعني ده عيان لو عنده مالجنسي بيجي له ثرومبوزس، لو عيان محجوز في المستشفى وراقد هيجي له ثرومبوزس، عنده ميجر تروما، عنده هاي ريسك سيرجري. لو عنده واحده من دول او عنده 2 من الماينور ريسك فاكتورز اللي هي الاوتو اميون ديزيزز او سيفير انفكشن او الكاثيتر انترودكشن او الهرمونال ريبليسمنت ثيرابي لونج ديستانت ترافل، لو عنده حاجه من الحاجات دي كلها هياخد 1. لكن لو جاله ثرومبوزس من غير ولا واحده من دول، ده كده هياخد سكور 3. تاني كلينيكال دومين الارتيريال ثرومبوزس، ماكروفاسكولار برضو ارتيريال ثرومبوزس، وبرضو بيتكلم على قسمهم جزئين. عيان عنده arterial thrombosis with high cardiovascular risk ده 2، لكن عيان جاله arterial thrombosis من غير ما يكون عنده cardiovascular risk. الكارديوفاسكولار ريسك زي ما احنا عارفينها السيفير هايبرتنشن والديابيتس والهايبرلايبيديميا وكرونيك رينال ديزيز. لو عنده حاجات سيفير يكفي واحده كرايتيريا، لكن لو عنده من المودريت كارديوفاسكولار ريسك يبقى محتاج 3 علشان اقول ان العيان ده عنده هاي كارديوفاسكولار ريسك بروفايل. نيجي بعد كده المايكروفاسكولار زي ما احنا شايفين في سسبكتد في عندنا حاجه اسمها ليفيدو راسيموزا، والليفيدو راسيموزا اللي هي شكلها دي بتختلف عن الليفيدو ريتيكولاريس ان الشبكه بتاعتها بتبقى متقطعه كده. فدي واحده من الكرايتيريا. لو احنا شفناها في عيان بنشك ان عنده فاسكولايتس او عنده انتي فوسفوليبيد سيندروم، ودي دايما بنقولها لطلبه البكالوريوس. اول ما تشوف العيان منقرش جلده كده فكر في حاجتين، يا انتي فوسفوليبيد يا اما فاسكولايتس او ليفيدو فاسكولوباسي او نيفروباسي او بالمونري الفيولار هيموريج. لو العيان عنده established criteria لا ده بياخد 5. لو تأكدنا فعلا انها عنده renal disease due to antiphospholipid مثلا من بايوبسي ظهر فيها ثرومبوزس، ولا البرونكو الفيولار لافاج اكد لنا العيان عنده pulmonary alveolar hemorrhage، لا العيان في الحالة دي بياخد 5. طيب نيجي بقى للحاجة المهمة بتاعتنا النهارده اللي هي الاوبستاتريك. في الاوبستاتريك الحقيقة حطوا لها تفاصيل كتيرة قوي، قسموها بري فيتال وفيتال، وقسموها عيان عنده بري اكلامسيا مع بلاسنتال انسفشنسي، وعيان عنده بري ويز اور ويزاوت بلاسنتال انسفشنسي ادوها 3، ويز سيفير انسفشنسي الاثنين مع بعض يعني البري اكلامسيا والبلاسنتال انسفشنسي ادوها 4. خلينا نمشي مع دي كده واحده واحده بما ان احنا النهارده في المؤتمر بتاعكم. لما كانوا بيتكلموا على الاوبستريك دومين بتاع بري فيتال اند فيتال ديس، قالوا ايه البري فيتال ده؟ البري فيتال ديس يعني عيانه حصلت لها pregnancy loss before 10 week and 0 day of gestation. طب الفيتال ديس ايه؟ الفيتال ديس قسموها early وليت. early فيتال ديس ما بين 10 weeks 0 and 15 weeks that 6 day of gestation، والليت بقى اللي هو ما بين 16 weeks 0 days and 34 weeks 0 days of gestation. نيجي بعد كده قالوا نخلي بالنا برضو ان احنا لو ما قدرناش فعلا نحلل البيبي اللي نزل ده او كده بنعتمد شويه على الكلينيكال جادجمنت. تاني حاجه اتكلموا عليها البري اكلامسيا. كلنا طبعا عارفين البري اكلامسيا والسيفير فيلير. يعني ايه بري اكلامسيا؟ سيستوليك بلاد بريشر اكتر من 140 او دايستوليك بلاد بريشر اكتر من 90 on 2 occasion at least 4 hours apart. فعيانه بعد ال 20 اسبوع اوف جيستيشن كانت قبل كده نورموتنسيف او هايبرتنسيف، والعيانه دي حصل لها ايه؟ نيو اونست اوف one of the following. جالها بروتينوريا 24 اور اكتر من 0.3، او بالديب ستيك كان عندها بروتينوريا اكتر من 2 بلس، وواحده او اكتر من السيفير فيتشرز بتاعه البري اكلامسيا زي سيفير بلاد بريشر اليفيشن، ضغطها عالي وصل ل 160 سيستوليك والدايستوليك 110 في قرايتين مختلفتين بينهم وبين بعض على الاقل 4 ساعات. جالها CNS dysfunction سيفير نيو اونست هيدك وهي مش متعوده ان يجي لها صداع، والصداع ده مش متفسر باي سبب تاني. جالها فيجوال ديستربنس، جالها pulmonary edema. كل دي ممكن يحصل مع السيفير فيتشرز بتاع البري اكلامسيا. جالها impaired liver function ودي بتظهر ان الانزيمز بتاعتها بتعلى او بيجي لها رايت هايبوكوندريال بين. جالها رينال ديسفانكشن وفي الحاله دي السيرم كرياتينين بتاعها بيعلى اكتر من 1.1 او بيحصل دبلنج للسيرم كرياتينين in the presence of renal disease، والثرومبوسايتوبينيا اللي بتحصل عادي مع الانتيفوسفوليبيد سيندروم. لما جم اتكلموا عن البلاسنتال insufficiency قالوا ان الانترايتراين fetal growth restriction defined as biometry estimated fetal weight or less than the 10th percentile for gestational age، او انه يكون عيان post natal birth weight اقل برضو من ال 10th percentile for gestational age in absence of fetal neonatal syndrome او genetic association تعمل لي هذا السبب. وكمان بيبقى معاهم واحده من السيفير الفيتشرز دي، يا اما يكون في فيتشرز تسجست فيتال هايبوكسيميا او في الدوبلر بيقول ان انا عندي ابنورمال دوبلر فلو فيلوسيمتري ويف اناليسيس. لما بنيجي نعمل للعيانه دوبلر ونشوف البلاد فلو في البلاسينتا اخباره ايه. برضو زي ما قلنا السيفير جروس فيتال جروس ريستريكشن، ممكن الاوليجو هيدرامنيوس كمان، ممكن بيبقى فيه كمان عندهم maternal vascular malperfusion on placental histology suggested by placental thrombosis أو infarction أو inadequate remodeling of the uterine spiral arteries أو decreased vasculopathy. بس هم حطوا لنا نوت هنا إن الحاجات اللي إحنا بنشوفها في البلاسينتا دي ممكن نشوفها في عيانة ما عندهاش APS أو ممكن نشوفها في عيانين APS negative patient، فعشان كده قالوا الحتة دي بالذات مش سبيسيفيك قوي للقصة بتاعتنا. نكمل الكلينيكال دومينز بقى. احنا قلنا الدومين نمره 5 الكاردياك دومين، قالوا الفالف ثيكنينج لازم نحترمه في العيانين دول، هنديله 2، ولو حصل فيجيتيشن اللي هي بنقول عليها ليدمانساك اندوكاردايتس هنديها 4. الثرومبوسايتوبينيا من 20,000 ل 130,000 دي حطوها واحده من الهيماتولوجي دومين، وقالوا لنا خدوا بالكم من الثرومبوسايتوبينيا لو هي اقل من 20,000 دي مش تبع الانتيفوسفوليبيد خالص، لو هي اكتر من 130,000 دي يعني لو سبيسيفيستي للانتيفوسفوليبيد، لكن لو لقيت العينه بتاعتك ما بين 20,000 ل 130,000 دي ممكن تحطها في الكرايتيريا بتاعتك. اتكلموا كمان عن اللابوراتوري دومين وقالوا ان حتى لو عندك لوبس انتي كواجولانت مره واحده بس بوزيتيف، احنا دايما كنا بنقول ان لازم يبقى الانتي بوديز بتاعتنا بينها وبين بعضها 12 اسبوع. قال لك لو مره واحده بس بوزيتيف هتديها سكور 1، لكن لو بعد بقى 12 اسبوع لقيتها بوزيتيف هياخد سكور 5. ولما جه اتكلم على البيتا 2 جلايكوبروتين واللوبس انتي كواجولانت فصصهم وقال الاي جي جي تاخد سكور لوحدها والاي جي ام على حسب ما لقوا الريسك بتاع الافكشن او المور ثرومبوزيس. يعني احنا شايفين هنا مثلا المودريت اور هاي بوزيتيف اي جي ام انتي كارديولايبين اند بيتا 1 ده حاجه صغيره، يبقى مفيش داعي بقى واحنا بنتابع العيانه نكلفها ونقول لها اعملي لنا بيتا 2 جلايكوبروتين اي جي ام، ملوش لازمه عندنا خالص في الكرايتيريا سكور 1. الحاجات الثانيه هي المهمه اللي سكورها عالي. طب انا اقول للعيان بتاعي عنده في انتي فوسفوليبيد امتى؟ لو العيان عنده 3 or more point clinical criteria plus 3 or more point laboratory criteria. وكانت الكرايتيريا دي حسبوا لها specificity و sensitivity، لقوا ان new criteria more specific and less sensitive than the old criteria. To summarize, the antiphospholipid new ACR criteria showed novel clinical feature، قالت لنا حاجات كتيره، فصصت لنا الماكروفاسكولار وعملت لها ريسك stratification، فصصت المايكروفاسكولار وعملت لها ويل ديفايند دومينز، حددت البريجنانسي موربيديتي وشرحتها وضحتها لنا، وكمان ادت نيو كرايتيريا بتاعت الكاردياك فالف. واللابوراتوري فيتشرز عملت لنا كوانتيفيكيشن للانتي بوديز وقسمت لنا الانتي بوديز اكوردنج تو ايزوتوبس وحددت لنا الليفل بتاع الانتي كارديولايتين بوزيتيفيتي. These are my references and thank you.
شاكرين جدا. Thank you Professor Dr. Dalia Abdel Mohsen for this very informative presentation. May I introduce the next speaker, Professor Dr. Burgard Arnstein. The title of his presentation will be Personalized Prolapse Surgery.
Dear Chair Lady, dear Chairman, dear colleagues, good morning. Thank you again to the organizers for the kind invitation to this wonderful meeting. I have no disclosures, but we see various defects, the total prolapse, cystocele, lateral, central, enteroceles, rectoceles, various defects, and we have various procedures. Concerning the technique, we can use native tissue, alloplastic, mesh, biological implants. We have various approaches, vaginal approach, laparotomy, laparoscopy, robotic or combined, with or without hysterectomy or with supracervical hysterectomy. And we can use different fixation points like sacrospinous ligament fixation, uterosacral ligament, the promontory, or even the pecten. So, but they all follow the same principle of prolapse surgery, which is reflected by the tent theory. If the top of a tent caves in, the walls may follow, and in the vagina, it's the uterosacral ligament that holds the top of the vagina. So we try to repair the uterosacrospinal ligament complex. That's what we do, and when we take the vaginal route, the sacrospinous ligament is very clear. We know how to reach it, but where is the uterosacral ligament? And this is more difficult to find. And there was a nice study by Delancey and Umek, the Austrian colleague. They showed that the uterosacral goes from the deepest part of the sacral bone and the coccyx to the posterior wall of the cervix and the upper vagina. And that's the point we reach when we come from the vagina, from the buttock, as you know. Now we have various procedures for the anterior and central compartment. The traditional colporrhaphy, We may use meshes, armed meshes, partially absorbable meshes, or titanized meshes. We may suture the mesh to the pelvic sidewall. We may use an anchored mesh or a mesh without fixation that holds it by itself. Using laparoscopic techniques, laparoscopic colposuspension, lateral suspension like Dubizon showed us, or the pectopexy. Same confusion in the posterior compartment. We may use Moskowitz procedure or vaginally with native tissue, the McCall procedure. We may use the uterosacrals for fixation, stitching into the uterosacrals. We may do a sacrospinous ligament fixation, or even use the semitendinoeus for apical fixation, shown by Horneman. We may use laparoscopic techniques, the posterior colposuspension, or coming from the vagina with the bilateral sacrospinous ligament fixation using a tape. We may also use a mesh in the posterior compartment, a complete mesh. So the question is, which procedure for which patient? Before we can answer this question, we have to ask more questions. Is it the primary procedure? Is it the recurrence? Which surgery was done before? How old is the patient? Is she sexually active? Is there concomitant stress incontinence? Is alloplastic material available? Is hysterectomy necessary? Are there patient factors others than just the prolapse, like comorbidities or hip problems for the positioning on the table? And last but not least, how about the surgeon's experience? Now, we are used to look at data, but excuse me, when we want to find decent data to answer these questions, it reminds me of a desert with some small oases. However, the Cochrane Review in 2016 found some data and provides us with some data. They say that using mesh and vaginal mesh reduces the recurrence rate. They also found that using mesh causes more repeated surgeries in the future. But they also said that de novo dyspareunia is less after the use of mesh. So we have to keep that in mind. The European Committee, Scientific Committee of the European Community, published a guideline of the use of mesh through the vaginal route. And they say in complex cases, and in particular after failed primary surgery, and in cases where native tissue repair has failed or is expected to fail, we may use mesh in the vagina. Now, based on that, and based on some randomized studies, Germany, Austria, and Switzerland published a guideline which is still valid, and they say they found that native tissue repair has accumulated success rate of 63%. With apical fixation, 69%. Without apical fixation, 54%. So when we do an anterior repair, we should add apical fixation in order to gain less recurrence rates down. We can reduce the recurrence rate by a third. When we use anterior mesh with apical fixation, 93%. Without apical fixation, success rate 83%. Again, when we use a mesh in the anterior compartment, we should also add apical fixation. How about posterior compartment? Only midline suturing, 86% success rate. Defect-specific repair, 70%. When we use mesh in the posterior compartment, cumulated success rate of 95%. So are we allowed to use mesh in the posterior compartment? There are no randomized studies, but in non-controlled studies, we could see a lower recurrence rate with posterior mesh. There is, however, no current reason to use mesh in the posterior compartment for the primary repair, and not so much for the recurrence. Grade of recommendation is 0. Level of evidence is low. Now, in Austria, Switzerland and Germany, we say the use of mesh from the vaginal route needs precise patient information, and it may be discussed in special indications. At present, we are not able to clearly define mesh indications for prolapse patients, but mesh may be used in recurrent or total prolapse, especially when it's combined with obesity, chronic obstructive pulmonary disease, or other generalized connective tissue weaknesses, and in levator avulsion, to name the most important ones. Now, when I am asked for an attempt of a personalized strategy, I would start with the central cystocele. The colporaphy is still a good method. When it comes to a higher grade of central cystocele, grade 3 or 4, it needs definitely apical fixation or a mesh. Same for the aged patient, and same for the patient at risk for abdominal surgery. The lateral cystocele has the option of various methods: anterior sacrocolpopaxy, lateral suspension of Duvison, or vaginal mesh. It's very often the patient's choice who leads us, and the surgeon's experience, but especially when it comes to a high degree lateral defect cystocele, then we may prefer the vaginal approach because we are there where the problem is. In recurrences, after traditional prolapse, when it comes to a recurrence in level 2, we may use vaginal mesh. In level 1, after traditional procedures, sacrocolpopaxy laparoscopically, or bilateral vaginal sacrocolpopaxy. After vaginal mesh, recurrence after vaginal mesh asks for laparoscopic sacrocolpopaxy or Dubizon lateral suspension. And recurrence after sacrocolpopaxy, we may use the vaginal route using a mesh or a tape. Does age play a role? I already mentioned that it does not really that much play of a role. If family planning is not finished, we may use a pessary instead of going into surgery primarily. And a nice subject in my experience is intussusception. Patient with a deep rectal intussusception can be treated by apical fixation, reducing or restoring the uterosacral ligament and the rectovaginal fascia with a mesh. So in summary, I would like to state that we face complex problems and we have multiple therapeutic options. It needs patient-oriented, specific strategies, and it needs good specialists, and the evidence is low. meshes are not for each patient and not for each surgeon. And in order to get more specialists, and in order to get more patient safety, we need good training for our surgeons, and that's what we are here for. Thank you very much.
Thank you, Dr. Berger from Styria, for this nice presentation. And now, before I take the pleasure of introducing our next speaker, I would like to express my deep thanks to the organizing committee for their kind invitation, especially Dr. Hatem Al-Gamal. And now I would like to welcome our next speaker, Professor Dr. Muhammad Amir, Ain Shams University, with the presentation titled SRM MAC 2021 Tool.
First, I would like to thank Professor Dr. Hatem Al-Gamal and the organizing committee for great conference. My lecture is about the American Society of Reproductive Medicine Mullerian Anomalies Classification 2021, or in short MAC 2021 tool. And this is the last or the newest classification system for the congenital malformations of the Mullerian duct. It has been introduced in November 2021 in the Journal of Fertility and Sterility, and it was introduced to overcome all the difficulties and the weak points in the previous classification of the Mullerian anomalies. Actually, the incidence of the congenital malformation of the genital tract, the actual incidence is not known, because some of these malformations is not symptomatizing or discovered late or not be informed to another or published, but it's supposed to be around 0.1 to 3.5% in the general population. The incidence might be increased if you are studying patients with fertility problems. It will be around 6%. In patients with recurrent abortions could reach 10 to 16.5%. And most common identified forms of these congenital malformations: the septate uterus, arcuate, didelphys unicornate, or hypoplastic uterus. These are the main classification systems of the Mullerian anomalies. The first and the most commonly used one is that of the American Fertility Society classification, which later its name changed to the American Society of Reproductive Medicine. And it was published and used since 1988, and this is the most commonly used, being an easy system of classification, and most of the gynecologists use it in day-to-day practice, and it is correlated to the pregnancy outcome. It was based on Botram and Jones' classification of the Mullerian anomalies in 1979. But the main criticism or the criticizing points in that classification system, it concentrates on the uterine anomalies and neglecting the cervical and the vaginal anomalies, and it lacks specific criteria of classification of subclasses in each main class of malformations. There are other systems of classification for the Mullerian anomalies: the vacuum classification by Opelt, the vagina, cervix, uterus, adnexa, and associated malformations; ASA and ASIN classification, which classify the Mullerian anomalies according to the embryologic origin; the Asia and SG classification classify also the malformations to 6 main classes, but it classify it giving it letters and numbers: C for the cervix, U for the uterus, V for the vagina, and it was very difficult to be used in day-to-day practice even by the gynecologist. And so these all the systems not properly used or not commonly used by gynecologists in day-to-day practice. And so the American Society of Reproductive Medicine board decided to make a new classification. Its purpose should be for an educational and management purposes. And so they formed a task force. And this task force formed not only by gynecologists, but is formed by all the physicians that are treating or facing cases with Mullerian anomalies, like radiologist, urologist, pediatrician, and general surgery or the emergency medicine. And this task force started to retrieve all the publications about the congenital malformations that was published since 1949 till 2018, and started to tabulate and put these malformations to main categories, which became 9 major categories, and in each category there is subclasses which with strict criteria to differentiate each of these subclasses. The main aim of the MAG 2021, which is the short name of the American Society Classification, was that it should be recognizable as based on the American Society Classification 1988, because it is the most commonly used one and the most easiest by most of the gynecologists. So it should be based on this classification. It should describe anomalies involving uterus, cervix, vagina, not only concentrating on the uterine anomalies, but include other types of these anomalies. It should standardize terminology to simplify communication and recognizability. That describing the malformations in descriptive words, not by letters or numbers. This will ease the identification through the scientific database, and any doctor can say, I have this patient with descriptors like obstructive hemivagina and right renal anomalies or so. It should educate providers on presentation, diagnosis, and management. Also, any provider who is not dealing with these cases in day-to-day practice, he can go to this site and explore this MAC tool, and he can know the presentation. The patient can present with that presentation and how to diagnose and how can you manage also. It should be applicable to providers across disciplines. If one pediatrician, we know that most of the publications or new publications about the malformations or so is published in gynecologic textbooks, but doctors that are dealing or seeing these cases might be pediatrician or urologist or surgery. He is not with recent knowledge about the newly discovered problems in these malformations, so he can go to this site and explore any recent information or recent knowledge about the problems that he faced. Should raise awareness of the range of variations that some of the congenital malformations associated with certain diseases. For example, the unilateral malformation like unicornuate uterus or so, it is in 95% of cases associated with renal anomalies. So this classification should raise awareness of the range of variations. Should promote patient awareness and support advocacy. Any patient can go to this site and know the presentation and the complications if she is not treated for her problems. So the MAC 2021 classify malformations into 9 main classes, added longitudinal vaginal septum, transverse septum, and complex anomalies to the main 6 classes of the American AFS 1988. These are the classifications. Just the Mullerian agenesis, not only one case of absent uterus, but it might be absent uterus or the uterus is presented as 2 strands fibrous band or 1 fibrous band, another uterine horn without functioning endometrium. So in this classification, you can see any subclass in the main class. You can complete absent uterus or present as 2 strands or so. This is applied to all these subclasses. So he defined the main classes to subclasses and putting strict criteria in describing the differentiation between these subclasses, and concentrated mainly in the uterus didelphys with septate uterus with longitudinal vaginal septum. So in each class, these subclasses, five important elements of classification. If I go to the tool of the MAC and then pressing about the Mullerian agenesis, patient presented with primary amenorrhea and on examination investigation there is no uterus, so it is Mullerian agenesis. You can go in this MAC tool to the Mullerian agenesis and pressing on the variant, you will find Mullerian agenesis might be completely absent uterus or 2 strands with the Mullerian duct, and giving you a drawing, and then you can click here. You will see the symptoms and signs and differential diagnosis of such case. You can diagnose it with ultrasound or hysteroscopy, the imaging techniques to reach the diagnosis, and the different modalities of treatment, whether it is medical or surgical. And if you want to go back to the main classification, you will press on this icon. So there is QR code in this site. You can go after pressing it to the MAC 2021, and then pressing on it, you will go back to this page. You can reach here at the end, click to here to view the ASRM MAC 2021. After that, you have the 9 main classes. By pressing on any of these main class, you will be directed to the subclasses, and then you can reach the diagnosis and know how to treat such case. For example, in the Mullerian agenesis, you will, after pressing it, you will get the variants, different variants of the Mullerian agenesis. Might be completely absent or just 2 strands present. And this is the information: uterus single, midline, uterine remnants, are widely divergent atrophic, are widely divergent atrophic. This is the different variants of the Mullerian agenesis. Cervix absent, vagina absent, and the different names for that anomaly. Mullerian agenesis, this is the different knowledge. And then you can press on the treatment that will direct you to the different lines of treatment. Either medical treatment, what is the indication of this medical treatment, and you can elaborate the different medications that could be used in such case by pressing on this icon. Vaginal dilation, the indications, the procedure, how can you do vaginal dilatation, the surgical methods, different surgical methods, and you can see even the videos of these surgical procedures. This example, we know that the embryology, the Mullerian duct produces the upper part and upper 1/3 of the vagina, but the lowest 2/3 vulva and female urethra developed from the urogenital sinus. I have 2 examples that showing that the ability of the MAC 2021 to accept more malformations that is not present in it. For example, this patient, 35 years old, presented primary infertility and dyspareunia. On examination, on taking history, she has regular cycle. And on examination, there is an obstruction here. There is no vaginal septum. We asked the patient to come back when she is menstruating. We found that there is blood coming out of the urethra of menstrual blood. And in further investigation, we found that the patient having urethrovaginal fistula with a transverse vaginal septum. This is not included in the classification of MAC 2021, but it could be added to the transverse vaginal septum. We can add to it another anomaly. The MAC 2021 can merge between the major categories and can accept different variants. Another case, this case also presented with primary infertility dyspareunia. On examination, we found that has incomplete transverse vaginal septum and with anterior opening just below the external urethral meatus. Further investigation of such patient, we found that she has a left unicornate uterus, right rudimentary horn, accidentally discovered dermoid cyst, and absent right kidney. This should be put in the main category of the unicornate uterus with a associated right rudimentary horn. But we can add to it the incomplete transverse vaginal septum. So the MAC 2021 can accept the merging between categories because no one classification could include all the types of malformations, especially the part, the lower 2/3 of the vagina, urethra, and vulva. Every few days you will find a new case report. There is no new malformation. So in conclusion, the MAC 2021 aims to categorize Mullerian anomalies in a simple and clear way using diagrams and descriptive terminology as a reference for performance preferred nomenclature, as an educational reference to study Mullerian anomalies and correlate presentation, imaging, and the treatment, to compare and contrast anomalies with one another, as a reference to aid in the diagnosis and treatment of patients presenting with symptoms suggestive of a Mullerian anomaly. Thank you.
Thank you very much, Professor Mohammed Amer, for this nice and comprehensive update about the MAC 2021. It's really interesting. And now may I present my dear lifetime friend and colleague, Professor Abdulatif Al-Kholi, professor of Ain Shams University, in one of his field of interest, which is recurrent pregnancy loss, and he's going to address us about antiphospholipid syndrome from Hughes to ACR. Professor Abdulatif.
Good morning ladies and gentlemen. طبعا شرف ليا اكون موجود في مؤتمر الاسم بتاعي اسم امراض النساء والولاده في طب عين شمس. وجود مورنينج مستر تشيرمان. الحقيقه طبعا انا كنت قاعد ومستمتع بالمحاضره بتاعت دكتوره داليا عبد المحسن استاذتنا طبعا في الروماتولوجي immunology. يمكن هتكلم على الانتي فوسفوليبيد من another perspective. يعني انا مش هناقش الجايد لاينز بتقول ايه وايه الكرايتيريا وامتى نقول ده عنده امتى نقول ده ما عندوش، عشان الكلام ده كله موجود في كتاب. انا هتكلم على كونسبت ازاي احنا بنتعامل مع الحالات وازاي احنا نقدر نعمل ستراتيفيكيشن للحالات، وهل الجايد لاينز دي معموله عشان نقف في الطابور كلنا، يعني احنا هنمشي كلنا ورا بعض محدش يخرج بره الصف، ولا في مجال للاجتهاد ان احنا نغير شويه في الحاجات المكتوبه، وهل في ادويه طلعت في هذا المجال من قبيل الصدفه، هل في حاجات كانت معموله لحاجات ثانيه وبعدين بالصدفه طلعت بتنفع في هذا المجال. يعني الفكره ان مشكله الفيلد العلمي انه في دايما خط رفيع قوي بين انك تمشي على المكتوب في الكتاب بالظبط وبين انك تشغل مخك وتكتب حاجه خارجيه. المشكله ان الشعره دي هتدفع ناس كتير انها تكتب حاجات خارجيه unindicated whether الحاله is not fulfilling الكرايتيريا انها تاخدها، وفي نفس الوقت زي ما الدكتور تامر قال في حاجات كتير قوي بلاسيبو ايفكت هتبقى العيانه ماشيه عليها وتضطر انك انت تكرر العلاج. انا الحقيقه دايما بقول للعيانه انا لا اجرؤ ان انا اوقف لك علاج you achieved a successful outcome بي واجي انا اشيل على مسؤوليتي ان انا اوقف لك العلاج المره دي فيحصل ميسهاب لاي سبب، يبقى انا ساعتها انا الغلطان. هناخد الحقيقه جزء من الهيستوري لطيف. انا مش هكرر طبعا كلام الدكتوره داليا لان هي يعني اكثر علما وخبره مني في هذا المجال، لكن انا بحب اتكلم على الجزء بتاع الهيستوري. انا مينلي عايز اركز ان في حاجات بتظهر بقبيل الصدفه وبتغير مجرى التاريخ. ان ستيوارت دي كانت يعني الكوين بتاعت انجلند وايرلند وسكوتلاند في القرن السابع عشر، وبعدين الست دي كانت الهيستوري بتاعها لطيفه جدا، ويمكن هم بيريليتر انها يمكن اول حاله في التاريخ ممكن تسمى ان هي كانت روماتولوجيكال او immunological disease. الست دي كان عندها almost she had 17 pregnancies and 11 miscarriages and none of her kids survived, although some of them had intrauterine fetal death or postnatal death due to non-obstetrical reasons. But however, she had 11 miscarriages and she did not achieve a single successful pregnancy. وده يمكن اللي ادى in the literature ان هي الكراون وراح للعيله الثانيه خالص بتاع كينج جورج، بعتوا جابوه من هانوفر ومسك الحكم، ومن ساعتها السلسال بتاع البريتش رويالتي كله ماشي في العيله بتاعت كينج جورج 1 والديسندنتس، نتيجه لان ستيوارت يمكن المرض اللي كان موتها كان مرض ايمينولوجيكال، لان لقوا ان كان عندها شويه حاجات كمان. جالها فيت مره يمكن ده يبقى سيريبرال فاسكولار مانيفستيشن، كان بيجي لها مايجريتنج جوينت بينز صغيره وكبيره سمول جوينت ولارج جوينتس، فقد يكون عندها one of the manifestations of an immunological disease وقتها. بعد كده طبعا الموضوع يعني كمل محدش لفت انتباهه لغايه ما واسرمان فون فاسر كان عمل واسرمان رياكشن، وابتدى القصه بتاعت الفولس بوزيتيف تيست فور سيفيلس، السيرولوجيكال تيست فور سيفيلس. وبعدين لقوا ان عدد كبير من العيانين قوي السولجرز في السكند وورلد وور لقوا ان هم كانوا بيتست بوزيتيف لهذا التحليل، although none of them had syphilis before. فابتدوا يفكروا ان there could be a different disease which tests positive to the false positive test for syphilis او الواسرمان رياكشن، اللي تحول بعد كده بفلوكيليشن تيست للفي دي ار ال اللي هو الفينيرال ديزيز ريسيرش لاب فيما بعد، والتارجت انتيجين بتاعه كانوا extracted from الهارت اوف البورساين هارت، فعشان كده سموه الكارديو لايتن. بعد كده لقوا ان في بعض العيانين لوبس they test positive for this disease، وبعدين لقوا بعد كده ان في antibody responsible for prolongation of the coagulation، وده اللي سموه اللوبس انتي كواجلنت. وبعدين بعد كده ابتدوا يربطوا ما بين البريزنس اوف لوبس انتي كواجلنت مع الريكارنت miscarriage وانتراتران فيتال ديث. يعني اللي عايز اقوله لغايه ما جاء سير جراهام هيوز في الفتره 1981 وابتدى يربط ان في سيندروم اوف ديزيز مش عارفين الناس عندها ايه، لكن ده بيسبب في ثرومبوزس وسيرابل مانيفستيشنز، وابتدى يسميه الهيوز سيندروم او الانتي فوسفوليبيد سيندروم. حتى كانوا الاول معتقدين ان هو دايركتد اجينست الفوسفوليبيد، وبعدين الكارديولايبين، وبعدين لا ده الفوسفوليبيد كلها، وبعدين قالوا لا ده الفوسفوليبيد بايندينج بروتين، عشان كده ابتدوا يطلعوه الانتي بيتا 2 جلايكوبروتين 1. الايفوليوشن اوف ذيس هيستوري طلعت واحد من احدث الامراض في القرن في الالفيه الثانيه، عشان كده حتى كانوا بيقولوا التو ديزيزز اللي احنا شخصناهم في الالفيه الثانيه كانوا الاتش اي في والانتي فوسفوليبيد سيندروم. بعد كده طبعا حصل الايفوليوشن بتاع التست انتي كارديولايبين انتي بودي واللوبس انتي كواجلنت والانتي بيتا 2 جلايكوبروتين 1 اسي، وده تقريبا ريزوميه ازاي المحطات اللي وقف عندها التشخيص بتاع الامراض المناعيه. انا حاطط ده عشان اقول ان احنا في عيانين كتير قوي بيفلتوا مننا، بنشوف عندهم اعراض ما بنقدرش نربطها بكلينيكال مانيفستيشن معينه، وفي ناس بيتست بوزيتيف لحاجات هم ما عندهمش اي حاجه. انتي فوسفوليبيد انتي بوديز ممكن تكون موجوده 5% of the general population، وده الحقيقه بيعمل ماساه كبيره جدا ان احنا بنشوف عيانين كتير جالها مثلا مسكارج قبل كده، ميسد ابورشن، او ساعات بيبقى بلايتد اوفم، وراحت للدكتور قال لها ده ميسد ابورشن عشان هو بلايتد اوفم، اعملي تحاليل، ومن ضمنها البانل بتاع الانفستيجيشن بتاعت الانتي فوسفوليبيد انتي بوديز، والعيانه كنت تيست بوزيتيف ترانزنتلي لوان اوف ذم، او حتى تبقى نورمالي بوزيتيف انتي فوسفوليبيد، وبالتالي العينه دي اتبصمت بالانتي كواجيليشن وتمشي عليه فور لايف. وده اللي بقول عليه ان احنا ساعات تو ماني انفستيجيشنز بتؤدي الى فولس بوزيتيفيتي وتريتمنت unindicated ولاك اوف كلينيكال سنس، بيمس سام بيشنتس محتاجين ياخدوا الدواء بس احنا بنحرمهم منه لان هم مش ماشيين على الجايد لاينز. الجايد لاين زي ما الدكتوره داليا اسبقت طبعا ابتدت بالسابورو كرايتيريا اللي الدكتوره داليا قالتها مش هكررها تاني، وبعدين ابتدت تبقى ريفايز في سيدني في ال11th ورك شوب بتاع الانتي فوسفوليبيد سندروم، وزودوا عليها الانتي بيتا 2 جلايكوبروتين 1. والحقيقه السيدني كرايتيريا وان اوف ذا موست اكسبتد، واللي خدت يعني باع طويل، الناس مشيت عليها فتره طويله قوي. بعد كده لقوا ان في عيانين نوت فولفيلنج الكرايتيريا وعيانين بياخدوا اللو دوز اسبرين واللو موليكيولر ريت هيبرين وذي دونت اتشيف سكسسفول بريجنسي، فابتدوا يفكروا طب ما نكبر القاعده شويه، ما هو ممكن عيانين يكون ما عندهمش 1 كلينيكال 1 لاب كرايتيريا ندخل معاهم ناس ثانيه، فابتدوا الحقيقه يعملوا نون لاب كرايتيريا ونون كلينيكال كرايتيريا. طب ممكن ناخد لو عنده كلينيكال ونون لاب، او ممكن ناخد لو عنده لاب ونون كلينيكال. المهم ده يوصل لنا الايديا ان مش كل العيانين will test positive for antiphospholipid antibodies او will have the typical criteria. لازم دايما نبص على تشخيص الانتي فوسفوليبيد ان الناس دول بيحطوا كرايتيريا to homogenize the population under study. يعني انا عندي دلوقتي عايز اجرب دواء جديد، عايز اعمل ترايلز، عايز اشوف الشانسز اوف سكسس، المفروض اجيب population homogeneous عشان لما اعرضهم للدواء اشوف الاستجابه بتاعتهم كلهم. ما ينفعش ان انا اجي بعد شويه اقول دي استجابت ودي لا، ويبقى عندهم فاكتورز كونفاوندنج ما بين الاثنين. فالغرض الاساسي هو homogenization for future research. بعد كده طبعا اليولار اي سي ار كرايتيريا في 2023 طبعا هي بالنسبه لنا كنيسه يمكن معقده شويه، بس الدكتوره داليا الحقيقه بسطتها جدا. هو يبقى العين عنده واحد كلينيكال واحد لاب، وبعد كده بيجمع سكور، وانا مش هكرر الحاجات لكن الكلينيكال مانيفستيشن هي سهله، مايكرو فاسكولار وماكرو فاسكولار، الماكرو فينس وارتيريال، والاوبستاتريك بتاعنا والهيماتولوجي ثرومبوسايتوبينيا والكاردياك فالف ابنورماليتيز. والاوبستاتريك احنا عارفينها، انا هكرر بس النقط بسرعه. هي فيتال داث قبل 10 اسابيع، بعد 10 اسابيع قسموه ايرلي وليت، قبل 16 وبعد 16، وبعدين سيفير في الاكلامسيا واحنا برضو متفقين عليها، وزودوا معاها البلاسنتال انسفشنسي دي كرايتيريا اوف سيفيريتي برضو مش هقف عندها، وزودوا معاها البلاسنتال انسفشنسي كوان اوف ذا انديكيتورز اوف الاوبستاتريك دومين اللي هو دومين 4 بتاع انتي فوسفوليبيد، وحطوا اللاب كرايتيريا 7 و8، وحطوا لكل واحد من دول زي ما الدكتوره داليا وضحت يعني سكور اقوى لبعض الحاجات عن حاجات. يعني خلاص بقى الاي جي ام اللي كنا بنقول انفكشن ريليتد ودراج ريليتد، لا خلاص احنا بنتكلم على الاي جي جي والبوزيتيفيتي، وده بيطلع كمان الكونسبت اللي هو اتقال قبل كده ان هو ممكن يبقى عندك تريبل بوزيتيفيتي او بيرزيستنت بوزيتيفيتي بتاع اللوبس انتي كواجلنت one of the most dreadful predictors of a bad obstetric outcome بالنسبه لنا. although طبعا ان الاي سي ار كرايتيريا دي حاجه معموله عشان to set good statistics وترايلز، لكن ستيل برضه هي قللت السنسيتيفيتي، يعني you can miss a lot of patients much more than the Sydney criteria او revised Sapporo criteria. الباثوجينيسيس دي النقطة الثانية اللي عايز اتكلم عليها. مش مجرد التشخيص ممكن يمس some patients او كرايتيريا ممكن تمس some patients او كرايتيريا ممكن تؤدي الناس تعمل unindicated lab او يبقى العيانة typical clinical antiphospholipid وانا ارميها بره التفكير بتاعي لان هي اللاب بتاعتها نيجاتيف، واحنا عارفين كويس قوي ان اللاب دي حاجات كتير قوي بتبقى مش معموله صح. احنا بنعافر عشان المعمل يعمل لوبس انتي كواجلنت بتو باثويز اكسترينسيك وانترينسيك وتوضح له ان هو لازم يتعمل بتو ديفرنت باثويز، وتلاقي المعمل راجع لك بتحليل ثاني خالص، او العين عامله واحد بس اللي هو الموجود عندها. فاحنا اكشولي احنا بنعافر في حتى التحاليل، بنعافر هل احنا اللي بيعمل كوركشن بعد الاديشن بتاع الفوسفوليبيد ولا ما بيعملش كوركشن، مش بتتصلح بالبيشنت بلازما. فالقصه ممكن عيان فعلا يفلت من الدايجنوزس. انتي فوسفوليبيد انتي بادي سندروم مش هتكلم في الباثوجينيسيس، لكن هو حاجات كتير قوي. في حاجات بتتعامل على السيلز، على الاندوثيليوم، على الكومبلمنت، على الكواجيليشن كاسكيد، على الاكتيفيشن بتاع سام كواجيليشن فاكتور، على الادهيجن مولكيولز، على اي كام وفي كام. يعني في بلانتي اوف باثوجينيسيس، بس هنخلينا نميل اكتر بالانتي فوسفوليبيد. بالنسبه لنا كاوبستاتريكس اتس rather than a thrombotic event it's an inflammatory event. ده يفتح المجال، وطبعا بلس الجزء طبعا الجيناتيك بيفتح المجال طبعا قدام الكلاسيك ميديكيشنز اللي حضراتكم كلكم عارفينها. اللودوز اسبرين طبعا متفقين عليه 100 ل 150. اللو موليكيولر ويت هابرن وذر هندي البروفيلاكتيك دوز او هنعلي الدوز بقى على حسب الريسبونس العيانين اللي هم فيل. طب يا ترى الريفراكتوري اوبستاتريك انتي فوسفوليبيد ايه التولز اللي احنا ممكن نستعملها؟ هبتدي بالهيدروكسي كلوريكين، الحقيقه الدواء السحري اللي كنا بنتكلم عليه، يا ريت مصطفى فؤاد كان موجود في القاعه. كنا بنتكلم عليه long time ago. We used to use chloroquine upon patients with resistant antiphospholipid syndrome, and يعني كانوا بيقولوا عليها مجانين ايه الفلاكينين اللي بيتاخد في عينين antiphospholipid syndrome. and nowadays الحقيقه هو approved even باليولار في اليوز بتاعه في refractory obstetric antiphospholipid syndrome. safety documented during pregnancy, a marvelous drug. وعشان بس نبقى فاهمين الدراج ده كان برضه من قبيل الصدفه، يعني دواء ملاريا طوروه، طلع بعد كده فيرجن جديده منه، اكتشفوا ان ما عرفوش الحلفاء يخشوا على الالمان عشان مرض الملاريا خلص عليهم، فالالمان باير قالت لهم تعالوا دوروا ايه الماده دي، راحوا عاملين الكلوروكين ثم الهيدروكسي كلوروكين، والامريكان سرقوه منهم او هم اللي دعوه، كل واحد بيشتم في الثاني. المهم طلع في الاخر الدواء الهيدروكسي كلوروكين اللي هو بالصدفه لقوا بعد كده ان هو بيستخدم كويس قوي في العيانين اللي عندهم بيعملوا بروفيلاكسيس اجانست دي في تي بعد السيرجي بعد الهيب ريبليسمنت. وبالتالي دواء ابتدى زمان بيستخدموه في الملاريا، بعد كده بيستخدموه بتوع العظام في العيانين اللي هم يعملوا هيب ريبليسمنت تو بروفيلاكت اجانست الدي في تي. وبعدين دلوقتي دخل في الروماتولوجي، وبعدين بقينا نستخدمه عندنا في الاوبستاتريك انتي فوسفوليبيد سندروم. لو كنا قفلنا دماغنا زمان ان الدواء ده ما ينفعش عندنا، كان زمان ما وصلش الريفوليوشن بتاع الميديكيشنز، وناس كتير اتشيف سكسس الحقيقه بعد فترات طويله من المعاناه. نفس الكونسبت بالظبط. انا مش بقول الادويه دي النهارده هي ستاندرد او النهارده هي بتستخدم، انا بقول لازم يبقى عندنا رقابه من التفكير ان في medications, a lot of medications are knocking our doors, and one of those days many of these medications will be incorporated into the medications of the patients who fail to achieve a successful outcome بالستاندرد تريتمنت. احنا النهارده بندي العيانه اسبرين، بندي العيانه لو موليكيولر هيبرين، وبعدين بقينا دلوقتي معظم الناس بيدي هيدروكسي كلوروكين ويزود الجرعه بتاعه اللو موليكيولر ويت هيبرين ويدي ثيرابيوتيك، وبالعافيه ممكن يدي العيانه كورتيكوستيرويدز اللي كانت ماتت زمان على فكره، وقالوا دي بتعمل جيستيشنال دايابيتس وبتعمل مشاكل، ورجعت تاني دلوقتي بنتكلم في جرعه 15 ل 20 مللي جرام ولو بلاسنتال ترانسفير ولو ريسك اوف جيستيشنال دايابيتس. يعني كمان النهارده في ناس بتتكلم على البوسيبيليتي اوف ادمنستريشن اوف بريدنيزولون during the first trimester up to 14 weeks بيقلل الباد اوبستاتريك اوتكم. الايكوليزيماب نفس الكلام، طبعا هو بيستخدم اكتر في الهيموليتيك يوريميك سندروم، لكن برضه one of the off label indications بتاعت الايكوليزيماب اللي هو سوليريس في العيانين عندهم ريفراكتوري في الهالب سندروم. التيومن نيكروتيك فاكتور الفا انتاجونست نفس الكلام برضه، اتعمل ترايل هو الامباكت ترايل اتعملت على الترتوريزوماب واتشيف سكسسفول اوتكم. نفس الكلام برضو على الادينيوماب. اللوكورتوز زي ما اتفقنا up to 14 weeks. This is one of the proposed protocols. مش بقول ده guidelines. This is one of the proposed. It's not mine. بس looks like a nice one. انك انت ايه الحاجات اللي ممكن تزودها step by step في المرحله اللي بعدها. Intravenous immunoglobulins, high dose of vitamin D. Statins will be one of the state of the art shortly في prophylaxis against preeclampsia and in the treatment of antiphospholipid syndrome. Yet it's not حتى الآن documented. بس one day it will be one of the marvelous medications. تكرالمس نفس الكلام في الحالات. The new era كمان هيبتدي زي قصة الجين مابينج. I'm almost done this last slide. الجين مابينج نفس الفكرة ان العيان ده ممكن ياخد دواء ضغط، العيان ده ياخد دواء ضغط مختلف تماما. بيتا بلوكر مش هينفع لكل العيانين. نفس القصة برضو دراسة ال HLA تايبنج والاسوشيشن بالديفرنت تايبس او نماذج من انتي فوسفوليبيد سيندروم. ايه الاتش ال اي تاب بتاع العيان اللي يخليه مور برون تو ثرومبوزس، ونفس العيان عنده ايه تاني ممكن يخليه نوت امينبل تو ثرومبوزس لو الاتش ال اي بروفايل بتاعه مختلف. Still there is a long journey to reach. شكرا جزيلا ومؤتمر سعيد ان شاء الله.
شكرا دكتور عبد اللطيف خولي. Our next speaker is Dr. Jakobson. He's going to talk about Born Too Soon, a decade of action.
So thank you very much, and thank you very much for the kind invitation to come to Egypt. It's for the first time for me in Egypt, and it has been a marvelous experience. I'm really happy to be here and be a part of this where knowledge really started some 3,000-4,000 years ago with a big library and many other kind of things. So I'm so happy for the invitation. Thanks to the scientific committee and the people around here supporting. So I'm going to speak to you about public health. And I choose to speak about public health because that is the most important and most effective way of affecting pregnancy and pregnancy outcome. I will give you some, I will come back to that shortly. This is a little bit of a busy slide, but in the middle you see here, that the preterm delivery rate has really not gone down. But on the neonatal side, they have been very effective. They are reducing the neonatal morbidity. And they are doing it not by the high-hanging fruit. You see the lamb in the bag. That will not reduce the survival in the long term for babies. It is the simple things. It's putting the baby on the belly of the mother. Published in New England Journal 2022, reduction 25 to 30% from 1 kilo and up. Put the baby there directly and it had huge effect. On our side, on the obstetrical side of this, we have some simple things to do. Don't deliver babies before 37 weeks if you don't need to. Don't put 2 eggs back when you're doing IVF. Put 1 egg back. Choose the right time to do IVF. Some very simple things. I will come back to you another one. But I'm on the high-hanging fruit here. So I'm doing genetics and publish them in the highest ranked journals. This is the second paper that I published on genetics for parturition and the links to fetal birth weight. It was in Nature Genetics. It was following up the New England Journal paper that we published years before. The kind of trade-off for these findings will not happen in short time. It will take decades before we can use this information that we publish. Here's another paper that we published on placental weight in Nature Genetics last year. And here is one we published in Nature Communication a couple of weeks ago on the neonatal jaundice in different ways. So I come from this kind of very high-hanging fruit perspective on this. But I decided to start to work in FIGO, and I became the chair of the FIGO Committee of Preterm Birth. We decided to try to focus on the absolutely most simple things to do and put out an issue that is open access. You can download it. What we can do, simple things that we can do. It is the things that I just told you about, don't deliver babies before 37 weeks if not needed, don't do cesarean section when if not needed, put the belly on the mother's breast as soon as possible, late cord clamping, and many of those things we really promoted. We also made recently a progesterone cyclase pastoral oversight to do this. But I think it's very important to remember that all those things will not have any big effect on your preterm delivery rates, but it will have much more than if you focus on progesterone cyclase or even pessary, that is quite out of business right now. And we need to have solid data for this. So, but still, it will not have huge effect. So therefore, we decided to continue to work with advocacy because there are some simple things that we can do. Use antenatal corticosteroids, use magnesium sulfate, do delayed cord clamping on preterm delivery, to promote breastfeeding, do kangaroo care. Easy things, doesn't cost a lot of money. On the other hand, you can't earn money from this, but you can earn money for the society. Because if we do these simple, cost-effective things, the society benefits from this, because this will really have big effect. Progesterone cyclase will not have that kind of effect. It might have important outcome for the babies, yes, and the individual woman, but not for the population, not in the big run, not for the whole society. And therefore, it's very important to do this. So FIGO and I took the initiative with WHO and our organization to do a new Born Too Soon report. The first came 2012, and now we wanted to do an update. And the result is quite frustrating because there haven't been any reduction in preterm delivery. So it shows that the preterm delivery rate is still around 10% on the global level. 80% of those babies are born in low and middle income countries. And so the burden is most where there are less resources to this. And in some countries like India, there is 3 million births a year that are preterm. So it's a huge numbers, but no reduction. And still, it is the most common cause of death of children less than 5 years, and also the long-term morbidity, the kind of burden of disease from neonatal disorders is still the same in the world from 1990 to 2019. It's very important to remember that. So we came together, 140 individuals, to 5 countries. I was the core editorial group, co-editor from the maternal side. We also led the global advisory group, and we work a lot with advocacy. And this talk is part of that advocacy. Try to promote the simple things that we can do. And FIGO was involved in many of these issues. And you also heard from the talk of Professor Chiara yesterday how important public health is related to the outcome of maternal and newborn health. And here is the overall picture. And you see in the bottom here, that is pretty much public health issues and how you build society and how you work with it. Also up in the left corner, you can see it. But the island of medical diagnostic technology and treatment is quite small. And we need to build this kind of healthcare around universal healthcare coverage and primary healthcare coverage. So remember, I came from this genetic field, try to understand the timing of delivery, but this is the main important thing that we can do, and it's so much more effective and things like that. And therefore, we need to take a national leadership, we need to take a regional leadership, we need to work with society, we need to work with the politician and influence them to make the big thing. You see here the pillar. The old Egypt will not build a pillar with this small kind of medical intervention perspective. They will put a big pillar in the middle. And we have responsibilities for this as doctors because we have the knowledge. And obstetrician gynecologists is not on the top of the globe when it comes to influencing politicians and civil servants who is working with these issues. The book had different chapters. We looked at accounting for preterm birth. We also had a new chapter that was not in the last iteration, that is a right and respect, putting people in the center of response to preterm birth. Women's respect, women's reproductive rights, women's right to decide over their own body. And we also had a new chapter, Chapter 6, that is intersectorial action. I will come back to both of these chapters. And the chapter on women's health is Chapter 4. We are also translating this. This is a free report. You can download it from borntosoon.action.org whenever you want it. But we're also now doing a kind of version of it, putting in the public domain for research, so it will be easy download in BMC Women's Health. And that is the journal that take all this. And what did we conclude then in the Chapter 4 on women's health and maternal health service? We need to seize the missing opportunities to prevent and manage preterm birth. A major emphasis on the government and civil society and private sector and all development partners must join forces together to ensure effective integration of sexual, reproductive, and maternal health services within the universal health coverage, as well as integration of the action of known modifiable risk factors for preterm birth. And the other pivot is focusing on improving the quality and experience of care, taking care of women families in a way that make them come back and ask for more help. And for women and adolescents before, during, and after childbirth. We also need full leverage of existing tools to improve the management of preterm birth, including magnesium sulfate, antenatal corticosteroids, the Premprefide that I show you, breastfeeding of the babies, delayed cord clamping, and many others. We also need to ensure that women and families receive respectful and person-centered care, and especially those that are most exposed to this. And we need to respect women and families' voices in this setting. We also, in all these chapters, wanted to give a personal story in different way, or a kind of country snapshot. And one we had for Chapter 4 is the Green Way. It's about the movement in Latin America where they have kind of, even though it is a Catholic part of the world, really have been able to change legislation to improve the coverage and accessibility to contraception and to abortion. That means women's care, that women need to be able to decide over their own bodies. And this was two of the chairs from Figo's Contraception Committee, Aparna Sidkar, and Figo's current chair of Safe Abortion, Laura Gill from Colombia. They are working very heavily on these issues and very important. And here you have an example also of a country snapshot responding to high adolescent fertility rate. So Chile adopted a regional Antenium plan for prevention of adolescent pregnancy, aiming to reduce the adolescent fertility rate by 10% by 2020. So they really did that multi-sectorial time-pronged strategy to implement, involving training health workers, creating adolescent-friendly spaces in primary healthcare centers, promoting range of contraceptive methods, improving outreach and referrals, and improving school retention and re-entry of pregnant adolescents and adolescent mother. The strategy was supported by enabling laws and policies, including collaboration between key stakeholders, including research organizations, civil society, and youth and women's advocates in this way. And it really, they were very successful with this, and they succeeded with their idea about this. Here is another example, country snapshot from women's health perspective. And it is the first, it is promoting the use of antenatal corticosteroids in Cambodia, and they were very successful in this, in improving this. But now, so that was the maternal chapter, what we saw as the pivots that was needed to be done there. We also had a new chapter on the intersectorial influence. We need to be, as doctors, as obstetricians, gynecologists, be very much involved in promoting these kind of activities in the society, because it will really help to promote the outcome of pregnancy and women's overall health. And we said that there were 5 E's here. It's equity and rights for women. It's economic, reduce the numbers out of pocket payment, environment, emergency, and education. So the pivot one, equity through gender-based transformative right-based policies across sectors. Policies and frameworks should promote sexual and reproductive health and rights to women's bodily autonomy and agency, and especially addressing harmful gender and social norms such as child marriage and mutilation, genital mutilation. Very important. Education, especially women's education, is so important because it really affects the whole family, the whole society, and it's one of the key components on women's health. A life cycle approach of education is required to ensure a healthy start and early childhood development of the children, and also be able to understand and use different kind of contraceptive methods. We also need to have an economic investment that are much smarter with co-financing across sectors, universal health coverage, and minimizing out-of-pocket payment. I will give you some example of that shortly. Environment and adaptive systems, water and sanitation. It's so important to invest in this. And also environmental preparedness and responses, especially in human, vulnerable and human settings where the most kind of worst kind of situations are. We need to invest in this. And we have been able to show in our country snapshot, here it's from Zambia, that working with comprehensive sexual education in school is very effective in reducing the number of teenage pregnancies. So this is the things that we really need to work, and we really need to promote this in society. Here is how we can support breastfeeding in Burkina Faso, also showing that you can breastfeed in public and how that affected and try to affect the norms. And breastfeeding increased in Burkina Faso during this time period. But in summary, there are 2 priority tracks in the Born Too Soon report. It's to prevent preterm birth, and it's to improve neonatal care. And the prevention of preterm birth is the preconception care, including family planning, that is a wanted pregnancy is absolutely the most safest pregnancy. And therefore, women's rights and family planning is so important. And the natal care and high quality antenatal care, it's not only the numbers of visits, it's the quality of that. And childbirth care, including reducing the provider-initiated birth and unnecessary medical intervention. And use these kind of intersectorial intervention on nutrition goals, education, mitigation of climate changes, etc. So it's so important. During birth, it is what I talked to you yesterday about, it's the PrEP 5. It's magnesium sulfate, it's antenatal corticosteroids, it's delayed cord clamping, it's a breastfeeding, and kangaroo care. So important that we use that and practice that. On the improvement of newborn care, if we focus on, you see the kind of pyramid It's not the Egyptian pyramid, but it's the number of preterm birth there in the middle, in the bottom. It's 11.4 million. They are born between 32 and 37 weeks. They don't need level 3 high neonatal care. They need now 2. And you can do so much on level 2 when we can really improve the those outcomes. And we have this kind of gap because in high-income countries, 9 out of 10 babies survive being born at 28 weeks, and low-income countries, it's 1 out of 10. So this is very important. And how do we do that? We need to invest, we need to implement, we need to integrate, and we need to innovate. And we need a calling from the leadership for leadership and action from the top. We need to do advocacy to the top of the society that they are able to promote this kind of activity and support that, but also build grassroots movements to have patient organizations that we are working with. And we are poised to act, and progress is really possible. The first thing we need to do is to invest. Society needs to invest in healthcare, universal healthcare and primary healthcare. That is absolutely the most important thing. And here is an example of one of the richest countries in the world. United States is my first PhD student. He is now a professor in Galveston. He was driving to work, and somebody with a big sign, "I got the preterm delivery. I need economic support." How could a country with highest income country in the world don't have a health system that provide a situation like this to help that family? How to be able to provide money out of pocket. So we need to build societies that take care of this. We need also to implement partnership with women and families. And this is so important. And we need to build adopting the right policies is necessary, and that builds trust. And we should use all those kind of possibilities that we have in different ways. We should also integrate. The activities of other sectors in the society matters. Intersectorial sectors in the report identify 5 intersectorial domains affecting maternal and newborn health, especially the most vulnerable: equity and rights, environment, economic issues, education, and emergency. And particularly climate changes poses a major but underappreciated threat to pregnancy and newborns. So intersectorial intervention can act as powerful health enhancers, contributing to health for mothers and babies. And finally, we also need to innovate. And innovation and certain and creative approaches must be employed, and new ways of working collaboration across the society. We need to have a much broader perspective than what we have in the delivery room, and so far, if we should do anything about this. And we need also to start to do much more research, especially implementing research. We need to learn from the examples. We need to record what we are doing. And we need especially a huge effort on women's and children's health. And we need to come together with government, funding organization, industry, and parent organization, and healthcare providers organization. Most of us here are healthcare providers, and as part of that, most of us are obstetrician gynecologists, but it's so important that we continue and work on this together. And how can we get there? You can be the national leaders in the Egyptian society on that. You can be the regional leaders in Northern Africa and bring this together, bring the politicians to the table, and make a huge difference. You can also step up to be a global leader and work here. And we need obstetricians, gynecologists here, because we see the problem. We see the effects of this together with the neonatologists, together with the midwives, together with the neonatal nurses and nurses. We really need to come together. World Health Organization is where we need you. We need you in UNFPA. We also need you in the advocacy alliance or partnership for maternal and newborn health. And the report was really driven from this leadership. And here is some of the former leaders of FIGO in the bottom left for you, and in the upper right is the former leader of ICM, International Confederation of Midwife, Frank Aguilera. We really need to be together on this. Sweden actually have a global health minister, and so there are possibility. And United Health System, this is a very slide, but we are there, and here you have where you find our issues of maternal and newborn health under the United Universal Health Coverage Life Course, and in the bottom here you see two departments working on this. It's the sexual and reproductive health research. It's Dr. Pascala Leite who is leading that together with Femi Oladapo. And yes, last week I was in Rome at the first Society of Maternal Fetal Medicine conference outside US. And Femi was there, and he said that on the question regarding maternal mortality, what can we do? He said that we can engage in the society much more, and we need to be involved in that. We also have another that is called Maternal, Newborn, Child and Adolescent Health and Aging. It's led by Anshu Banerjee, who is a fantastic leader in this, working on the broader perspective, and we have been working with them producing this report. But healthcare professional organization, we need to work together on the regional level, on the global level, and we have our president, FIGO president here, Dr. Ann Chiara, that we heard yesterday speaking about this. In the hospital world, it's quite hierarchical, but when we work in the global health arena, we work together with other professionals, and we need to be engaged there, because if we as doctors, obstetricians, gynecologists is not there, somebody else is there and promoting their kind of idea. So we need to step out a little bit of the hospital world. We need to come together. We need to speak to those with most influence in different ways in Health Economic Forum. And we need to educate and motivate OBGYN doctor, both experienced and young. It's very important. I can work on the main global health world arena, both within maternal health and within sexual reproductive health rights. And this is one of the things that I really learned during this experience, that our coming here to Egypt, most of you, I said that I'm an obstetrician. Of course, I'm trained as an obstetrician and gynecologist, but I never do gynecology except a couple of weeks in the summer. And but here everyone speaks that you are obstetrician and gynecologist. So it's the lifespan. It is the whole women's perspective that we need to be. And we need to be there and advocate for that. And in a way, the pediatricians have been on the global stage talking for global health, for women and health, especially children. But we are not there yet. The midwives are up there. The patients are starting to climb. But we're still on the outside. So I need your engagement in this thing. This goes for national, regional, and on the global stage. And we need to come up there. And I hope that I will see you coming up there and really come together. And this is the slide I also used yesterday. We can't only do guidelines. We have a medical problem. We want to solve that. We write a guideline. That is not enough. We need to work with the society or the kind of state and their kind of authorities to build a program around it, how it's implemented and how it comes to action. That's important. And especially also the third level here. We need to influence with the knowledge and that we have. We need to have outreach. We need to influence decision maker that our knowledge comes into action. We have a responsibility for doing that. It's a picture from a very impressive organization. It's a Federation of Obstetrics and Gynecology Societies in India. They have a huge meeting every year with 20,000 people coming together, FOXY. And here is the current president, Jagdeep Tank's inauguration. And he had coordinate, communicate, and community. I think that those three issues are underrepresented in many of our society. We are much too interested in writing guidelines, technical issues. We need to come together and really do this. We need to work with the community, and we have a responsibility with the kind of knowledge we have, the suffering that women and children really appreciate. So we need to do this joint effort for women's and children's health, and doing that together with society, together with the women and families, and together with society and industry, because we need all this effort. We need to come together, especially in this very difficult time of when with war and conflict. It's one of these big 3 C's: the conflict, the cost of living, and the kind of health crisis in many ways. So thank you so much. I will stop with giving you a little bit short summary here, that the majority of preterm births and disabilities are preventable, despite of flatline on the prevention and of preterm birth over the last decade. There are been important progress, and we should do that. We should have new global targets for maternal and newborn mortality, SDGs, and we need to be able to successfully do that. And I will say that every one of you has a role to play. If we can prevent preterm birth and ensure that babies born preterm can survive, this will be a huge contribution to improving maternal and newborn health around the world and achieving this sustainable developmental goals by 2030. Thank you very much. Thank you.
Thank you, Dr. Jakobson. Our next activity will be a symposium by Astrals titled The VMS and the Hypothalamus, a Novel Pathway to Temperature Control by Professor Dr. Hatem El-Gamal.
Thank you, Mr. Chairman. It gives me great pleasure to introduce this new concept in the management of the vasomotor symptoms in menopause, and this is newly launched for new drug which will has a role in the management of the vasomotor symptoms later on. Targeting the NK3 pathway. Can you please scan this slide? Which of the following best describes the vasomotor symptoms associated with menopause? Please vote. %, hot flushes and the night sweat. So which of the following describe the vasomotor symptoms? This is the hot flushes, 5% mode or 4% mode swings and irritability, frequent headache and dizziness, 3%. So 100%, we agree that 100% about the hot flushes and the night sweats, this is the most common vasomotor symptoms. Menopausal symptoms are heterogeneous, physiologically complex and interconnected. We have central nervous system changes regarding the hot flushes and night sweats, sleep disturbances, depression and anxiety, cognitive changes, and headache or migraine. Also, we have sexual problems, decreased sexual desire, dyspareunia, vaginal dryness, vulval itching and burning, together with some urological manifestations like dysuria, urinary frequency, and recurrent UTI. Regarding also the changes in the skin and the mucosal and the hairy changes, we have also weight and the metabolic changes, for example, weight gain and increase the visceral adiposity, musculoskeletal system, joint pain, and the sarcopenia. Hot flushes and the night sweats are often considered the hallmark or symptom of the menopause. What is the definition of the hot flushes? Episodes of sudden intense sensation of heat in the upper body lasting from 1 to 5 minutes and may be accompanied by sweating, chills, anxiety, and heart palpitation. Night sweats, hot flushes that occur during night. And we classify them according to the severity into severe sensation of heat and sweating causing cessation of activity. Moderate sensation of heat and sweating, able to continue activity, and the mild also or only sensation of heat without sweating. This is the classification. Hot flushes are the most commonly reported symptom of the postmenopausal women. About 74% of women will complain from the hot flushes. Sleepiness or sleep disturbances about 60%, mood changes about 60%, irritability about 53%, depression about 33%, and vaginal dryness and pain about 30%, and involuntary loss of urine, this is another complaint in about 28% of women. Also, the hot flushes are the most common reason to seek for the treatment. About 62%, this is the most common cause of the woman or postmenopausal woman that seek treatment is the hot flushes and not the other physiological changes that may occur. Vasomotor symptoms with multiple components of daily life, with the sleep being the most significant affected. These are the most two complain, hot flushes and the sleep disturbances. They accompanying each other 84% with 82%. Also we have some with mood changes with the hot flushes. Sleep disturbances exacerbate the significant burden of the vasomotor symptoms associated with menopause and on quality of life. Over 90% of women experiencing moderate to severe vasomotor symptoms reported interrupted sleep due to sweating or overheating. Over 50% of women reported that the vasomotor symptoms had an impact on the alertness, concentration, irritability, ability to get things done. Vasomotor symptoms associated with menopause has also linked to the cardiovascular diseases. Those women would have frequent or persistent vasomotor symptoms are associated up to 77% increase the risk of cardiovascular disorders. And those women also experiencing increase in the incidence of diabetes. Those women with vasomotor symptoms associated with about 18% increase in the diabetes risk. Also among those women with severe form of sweating and continuous vasomotor symptoms, among women reporting moderate severe vasomotor symptoms compared with the no vasomotor symptoms, the hip replacement for hip fracture with 1.7. This increase in the odd about 1.7, that's to say nearly doubling the normal. So what are the vasomotor symptoms and the hypothalamus? This is a novel pathway for the temperature control. Viso or visolentant, we can call it Viso. This is the new drug will be introduced, investigated in clinical trials for the treatment of the vasomotor symptoms in menopause. Acts by targeting which receptor? Can you answer, please? Anyone know? Yes, I think most of the attendees or the audience have the knowledge about the neurokinin 3 receptors and their role in the hypothalamus in controlling the thermoregulation. So actually, the physolentin actually affected the neurokinin 3 receptors that occurred in the hypothalamus. Globally, of course, we all know that hormonal therapy is recommended first-line treatment for the managing of the vasomotor center. That was previously. And this by the International Society of Menopause, by the European Society of the Menopause, by the Menopausal Society. All of them recommend the hormonal replacement therapy, and we was in this era of hormonal replacement therapy. Non-hormonal treatment options of vasomotor symptoms generally have limited evidence. For example, lifestyle modification, cognitive behavior therapy, some drugs like the serotonin release inhibitors, gabapentin, oxybutynin, moderately efficacy, and some limitations because of the safety considerations. Also the dairy supplements, over-the-counter supplements, and the herbal therapy, soya foods and extracts, all these have limited evidence. Following the release of the safety outcomes from the WHO, the WE study in 2002, use of the hormonal replacement therapy declined dramatically, and here you find the colors of the old prescribers, obstetricians and the gynecologists in the middle, in the lower one, and the other providers. You find that marked decrease in the use of the hormonal because of the safety considerations released from the study WHI in 2002. So the vasomotor symptoms arise. Why vasomotor symptoms occurs? Vasomotor symptoms occurs propose the mechanism. Number one, decrease the estrogen, decline the ovarian estrogen. Number two, thermoneural zone narrowing in the hypothalamus. Number three, alter the central and the peripheral nervous system activity. And number five, hypothalamic kisspeptine, neurokinin B, dinoferin neurons, which is called the KINDI neurons. So we will abbreviate it and call KINDI neurons in the hypothalamus. KINDI neurons in the hypothalamus play a very important role in the thermoregulation. And this is the KINDI. This is the KINDI neuron, and this is their thermoregulatory center. The thermoregulatory center in the hypothalamus acting by the activity of this neuron. This neuron is, when activated, it will stimulate the hot flashes. Estrogen suppressing the action of the KINDI neuron, but the neurokinin B stimulate the action of the neurons. In menopause, we have decreased the level of the estrogen. So this cell relieved from the depression or the suppression. So it will activate the thermoregulatory center or modify the action of the thermoregulatory center. And the neurokinin B is also released in the hypothalamus, acting in the neurokinin 3 receptor, stimulate this neuron, so it will activate this neuron. Our drug, physolentin, or we can call it physo, kidney neurons are inhibited by estrogen and stimulated, as I said, by the NKP in delicate balance. Estrogen decline during the menopausal transition disrupt the balance with the neurokinin B, triggering vasomotor symptoms. The physolentin is an oral, non-hormonal, selective NK3 receptor antagonist that blocks the action of the NKB binding. It is a drug. It is very acting by very important mechanism in the hypothalamus. It antagonizes the action of the NKB through the NK3 receptors. This is the main action. The NK3 antagonism offers a targeted approach to modulate the neural activity in the thermoregulatory center. Data from the fezolinetant phase 3 clinical trial program called the SKY study. In the SKY clinical trial, fezolinetant demonstrate which of the following effects of the vasomotor symptoms in postmenopausal women: significant reduction in frequency and severity, improvement in bone density and joint, minimal effect of the vasomotor symptoms compared to the placebo, complete elimination of all hot flashes. The answer: significant reduction in frequency and the severity of the hot flashes. About 90% showed significant reduction, and nearly 84% showed the significant reduction, which is actually occurs, but the number is more than the expected. Fezolinetant efficacy and safety were evaluated in 2 phase 3 pivotal studies. They make the study comparing the fezo with the placebo and following from day 1 after 1 week, after 4 weeks, after 12 weeks, and then after 1 year, 52 weeks. The results, the co-primary endpoint, mean change in frequency and severity of moderate to severe vasomotor symptoms from baseline to 4 weeks and 12 weeks. Secondary endpoint, mean change in the total score, mean change in frequency of severity and of moderate to severe vasomotor, and the baseline to each week up to 12 weeks, and the percentage of reduction at least 50% and at least 75% in the frequency of moderate to severe vasomotor symptoms baseline each week up to 12 weeks. Skylight, this is the selection criteria and the inclusion and exclusion criteria. And this is the hypersensitivity or the contraindication to the fezolinetant, assessing the vasomotor frequency and the severity in the fezolinetant phase 3. Clinically meaningful change in the vasomotor symptom frequency was defined as reduction of 2 or more episodes over 24 hours compared to the placebo. And the fezolinetant provided significant reduction in frequency. Significant reduction in frequency of moderate to severe vasomotor symptoms per 24 hours versus the placebo. Also, fezolinetant significant improvement in the severity of remaining vasomotor episodes at 4 weeks and at 12 weeks versus the placebo. The frequency of moderate to severe vasomotor symptoms was reduced by 63% at 12 weeks with the treatment with fezolinetant. That is to say, 2/3 of our patients will respond good to these drugs. The effect of the fezolinetant on the frequency of the moderate to severe vasomotor was evident after 1 week of start of use of the drug. So you can tell the patient after 1 week or 10 days, you will feel better. And the effect of the fezolinetant on moderate to severe vasomotor frequency was sustained up to 1 year. It will be sustained for 1 year, and if it can continue, it can continue, and it will sustain more. Fezolinetant resulted in improvement of moderate to severe frequency during day and night. Not only during day and night, from baseline to 12 weeks, fezolinetant reduced the vasomotor frequency versus the placebo, both daytime and nighttime. Over 2/3 of women treated with the fezo felt their vasomotor was much more better, moderately better at 12 weeks. يعني احنا عندنا about كده totally 69% بقى، ما بقاش 63%، بقى 69. 70% of women will be improved, but 70 up to 50% will show marked improvement, and 21% will show moderate improvement, and in general I have 70% will show improvement with the use of this drug. Safety of the fezolinetant has been studied in about 2,000 women with vasomotor associated with menopause during the phase. We have three important complications or side effects. Psychiatric disorders in the form of insomnia, and his common by definition is that it is less than 100 and between 10 and 100 patients can occur insomnia. That's to say 1%. Gastrointestinal disorders common also occurs in the form of diarrhea, but the most important is some changes in the liver function. The most frequent adverse reactions leading to dose continuation with fezolinetant were ALT increase and insomnia. So it is a must before you prescribe this drug to test the liver functions and the follow-up of the liver functions every 3 or every 6 months for the to be sure that there is no liver affection whatsoever, and it is a reversible effect if you find elevation in the ALT and you can stop the drug, and it has a reversible effect and no complications. In summary, in Skylight 1 and 2 trials, fezolinetant provided a significant reduction from the baseline in the frequency and the severity of moderate to severe vasomotor symptoms to weeks 4 to 11 compared to the placebo. The reduction in the frequency and the severity of moderate and severe vasomotor symptoms with fezo was observed by 1 week and maintained through 1 year. Among women treated with fezo, about 70% reported that their vasomotor symptom was much or moderately better after 12 weeks of treatment. Over 52 weeks, that's say 1 year, the most common adverse reaction with fezolinetant 45 milligram, this is the concentration, were diarrhea in about 3%, insomnia only in 3%. The most frequent adverse reaction leading to drug discontinuation, where that occurs only in 0.3% of patients, are the increase in the liver functions or enzyme ALT and the occurrence of the insomnia. Thank you very much. You can scan and answer some questions. Which of the following best describes the vasomotor symptoms associated with menopause? ما بشتغلش. The question 2 دلوقتي. Question 1. ها؟ خليها question 2 دلوقتي question 3 يعني. المفروض اوتوماتيك ما تطلعش في الاخر. Thank you very much. Thank you, Mr. Chairman.
Thank you, Dr. Hatem. As to the schedule, I have, there is a presentation or a symposium by Infinity regarding omega-3 in pregnancy and beyond. I don't know who it is. Nothing? Okay. Sorry for the miscommunication. Thank you very much. If you have any questions, please, for the speakers. Thank you.
السلام عليكم. أنا اسمي دكتور أيمن أبو النور. This is a sponsored session وبعد كده ال pre-term labor هيشتغل. أوكي؟ فنبدأ مع بعض دلوقتي. أوكي. هنتكلم عن الأوميجا fatty acids. This is the formula for the omega fatty acids. Omega fatty acids اللي هي فيها more than one double bond. في عندنا نوعين من الأوميجا fatty acids، في أوميجا 6 وفي أوميجا 3. الأوميجا 3 دول structural وanti inflammatory. يبقى احنا محتاجين ان احنا نزود الأوميجا 3. الأوميجا 6 لما يزيد يعمل preterm labor. المشكلة الاثنين are competing for the same enzymes. يبقى زيادة الأوميجا 6 يضر الأوميجا 3. زيادة الأوميجا 3 هيبقى الكويس. هنقول الكلام ده ليه؟ لأن we need omega 3. دي pathway. طيب لو احنا بصينا دلوقتي على الأوميجا فاتي أسيد بنلاقي إن ال DHA بيخش في البرين والاي ديفلوبمنت والكوجنيتيف فانكشن. احنا مجمعين دلوقتي ان ال DHA is structural بيخش في تكوين المخ والعينين، واللي ما يتكونش جوه it's not reversible. كلنا عارفين مخ البيبي 70% منه بيكون intrauterine، 20% في فترة الرضاعة و10% بعد كده، يعني 90% بيكون في الأول. يبقى البرين ديفلوبمنت محتاج اوميجا 3 فاتي اسيدز في التكوين. طيب هنديه بري كونسبشنال ولا ان بريجننسي ولا بوست بارتم؟ بري كونسبشن لما نديه بنبني الستورز. during pregnancy ال DHA مهم في البرين ديفلوبمنت كويس. الحاجه الثانيه ان ليه other effects، بيقلل preterm labor وبيحسن الديبريشن. بعد الولاده لازم نكمله. العيانه تيجي تسالك يا دكتور انا ولدت اكمل الفيتامينز والاوميجا؟ هو لا، مفيش حاجه اتغيرت. زي ما البيبي كان بياكل منك بره هو بياكل جوه هياكل منك بره. طيب دي بالنسبه للرضاعه. لو احنا بصينا كميه ال DHA في اللبن اللي هو الاصفر is very low. لو ادينا المذر اوميجا بيزيد 3 اضعاف، لدرجه ان الناس بتوع اللبن بيكتبوا على علبة اللبن الصناعي it is omega enriched. يعني هو بيغش، هو بيحاول يقلد لبن الأم، بيضحك علينا يقول لك ايه ده اوميجا enriched، وده احنا عارفين ان الاوميجا اللي في لبن الأم احسن كتير من الحاجات التانية. يبقى during pregnancy مهم للمذر، بيحسن ال DHA، بيحسن اللبن للبيبي برين واي ديفلوبمنت، بيحسن فيجوال اكيوتي والكوجنيتيف بيرفورمانس. طيب هل احنا محتاجين ولا لا؟ لقينا فعلا الناس observational studies الناس اللي بتاخد اوميجا فاتي اسيدز بيبقى فيه نيورو ديفلوبمنتالي احسن. وجم على البلاد اللي بتاكل اسماك كتير زي اليابان وسكاندينيفيانز بيبقوا احسن كتير قوي من البلاد اللي ما بتاكلش اسماك قوي. كويس. الحاجه الثانيه لو لاحظنا الاسماك في الاماكن البارده هي اللي بيبقى فيها الاوميجا كتير، اللي هي الاسماك اللي فيها دهن كتير، مش الاسماك في الاماكن الحاره. لقينا دلوقتي الناس اللي ما فيش سي فود انتيك بنلاقي الاي كيو بتاعهم اقل شويه والسكورز اقل. يبقى المذر لما بتاخدش سي فود كويس. طيب هل السي فود احسن لنا؟ السي فود كويس، بس مشكلته ايه؟ ان نتيجه لتلوث المحيطات والبحار بقى فيه ميركوري جوه الايه؟ الميه. السمك معروف عنه ملوش كليه، مفيش اسماك فيها كلى، فما تقدرش تطرد السموم، فدايما اي سم يبان فيه السمك. وزمان كان دايما يقول لك ايه؟ البحاره ما ياكلوش سمك ابدا يخافوا يتسموا. تمام؟ لكن احنا مش بنقول كده، احنا عارفين ان في اسماك كويسه، لكن احنا لازم ناخد بالنا ان السي فود كويس في الاوميجا لكن عيبه الاذرز. طيب هل الرضاعه نفس الكلام؟ اللاكتيتنج ويمن اللي ياخدوا DHA لقينا ان السكور بتاع البيبي بتاعهم هيبقى احسن. يبقى اذا هو كويس للحمل والرضاعه، وزي ما قلنا 70% من البرين بيتكون جوه، 20% اثناء الرضاعه اللي هم ال1000 الذهبيه بنسميهم الجولدن 1000 days. alright. اللي بعده نيجي بقى للالرجيز. لقينا احنا اتفقنا ان الاوميجا 3 بيحارب الاوميجا 6. الاوميجا 6 بيعمل لوكوترايينز اللي هي بتعمل الرجي. حتى من ضمن ادويه الالرجي زي السنجولار والحاجات دي حاجات ضد اللوكوترايينز. طب احنا عندنا حاجه ناتشورال ضد الكلام ده، فلقينا ان الاوميجا 3 اعطائه للمذر اللي هي بترضع بيحسن الالرجيز عند البيبي. وكلنا عارفين من زمان ان البيبيز اللي بيرضعوا طبيعي less liable يجي لهم ازمه او يجي لهم فود الرجيز او كده. تيجي واحده حامل تقول لك ايه ده البيبي الدكتور قال لي ما رضعش عشان البيبي عنده حساسيه. بنقول لو عنده حساسيه رضعي، ده هيبقى احسن لنا كتير جدا. الاذر فاليوز انه بيحسن البريتيرم بيرث، لان الاوميجا 3 ضد الاوميجا 6 اللي بيعمل اراكيدونيك اسيد وبروستا جلاندينز. اوكي، فهيحسن كمان الدبريشن. نيجي بقى مرض العصر الاوبيستي. مرض العصر اللي هو الاوبيستي. وجود الاوميجا 3 في الدايت بيحسن الجات مايكروبيوتا، والجات مايكروبيوتا كويس دي هتبقى كويسه للمذر وللبيبي. وكلنا عارفين ان الموضه العامه دلوقتي الميكروبيوتا هي الاساس، بدليل ان الواحده اللي بتولد قيصريه والبيبي ما ياخدش هيلثي مايكروبيوتا من الفاجينا يحصل له ريسك اوف اوبيستي تزيد عنده باي 50%. يبقى من ضمن الحاجات القيصريات من وحشتها ان البيبي ما بياخدش نورمال مايكروبيوتا. وفي ناس بتحاول تعمل تجارب دلوقتي ان ياخدوا الفاجينال سكريشنز بتاعت المذر وياكلوها للبيبي اللي مولود قيصريه عشان ما يبقاش عنده المشكله دي. دي اقتراحات لكن مش بنقول انها اثبتت لسه. اوكي، دي الاوميجا 3. ناخد بالنا السمك اللي موجود فيه زي الساردينز والسالمون كويسه في النيورو ديفلوبمنتال، بيقلل الالرجي، بيحسن البري تيرم ليبر. اوكي، احنا مهم عندنا اي بي اي ودي اتش اي. بما ان الدي اتش اي هو الستراكشرال فالريكوايرمنتس دايما بتتقال على الدي اتش اي ان احنا محتاجين 200 مللي جرام بير داي. اورايت، مهمين الاثنين وبالذات في البرين ديفلوبمنت. اورايت، طيب نقصه الديبريفيشن ممكن يعمل visual and behavior deficits. عشان اخده من الدايت هنحتاج 1 to 2 servings of salmon او حاجات زيه في الاسبوع. كيلو سالمون دلوقتي قرب ال 1000 جنيه. تلت السيرفنج تلت كيلو، تمام ولا لا؟ يعني 300 جنيه twice per week. يعني هتكلف 2500 جنيه عشان نجيب بس الايه؟ الحاجه اللي احنا عايزينها. السالمون والساردينز. الماكريل اللي فيه مش هو الماكريل اللي في مصر، ده نوع تاني منه. alright؟ عيب السي فود انه مليان توكسينز دلوقتي، فالاف دي اي بيقول لك اقصى حاجه 2 سيرفينجز، كل سيرفينج هيبقى تلت كيلو. الريشيو بقى، الريشيو احنا عايزين مصلحه الاوميجا 3 يبقى 1 to 1 او greater. اوكي، هل المذرز عندنا جايين انف ولا لا؟ في مصر المين سورس اوف دايت عندنا بلانت سورسز. طب ما الزيت الحار موجود فيه، بذره الكتان فيه موجوده فيه، لكن كميه التحويل من البلانت بيست اويلز الى الاوميجا از فيري لو. فعشان اخده من بلانت بيست هضطر اكل كميه فاتس كبيره قوي ما هياش مناسبه للحاله بتاعتي. دي زي ما قلنا ده اكل فيه اوميجا، طبعا اكل غالي جدا. سالمون، الافوكادو الكيلو بتاعه ب 300 400 جنيه، المكسرات ب 1500 جنيه كيلو، ما هياش من ضمن الحاجات اللي هي مناسبه قوي. كويس؟ يبقى البلانت سورس ال 20 يونت بيدوا 1 يونت. طيب نيجي بقى بالنسبه للاكل عندنا. احنا مشكلتنا ايه؟ ان اللحوم عندنا كلها معلوفه كورن فيد، بينما الدول الاجنبيه جراس فيد. الكورن فيد نسبه الاوميجا 6 18 ضعف الاوميجا 3، فاللحمه وحشه. اللحمه عندنا حتى اللي يسافر دوله اجنبيه مكتوب على اللحمه جراس فيد. مفهومه دي ولا لا؟ مفيش. احنا عندنا اللحمه كله بويزون فيد. مفهومه؟ يبقى اذا مفيش عندنا الكويس. يبقى اللحمه حتى عندنا مش مناسبه وبتضرنا. كلنا عارفين اللحمه عندنا بالذات تعمل اثيروسكلوز، تعمل مور دامج الحاجات. المكسرات عيبها ايه؟ ان الاوميجا 6 فيها كتير والاوميجا 3 فيها قليل جدا. يبقى دي مشكله ان الاوميجا 6 الريشيو برضو عاليه جدا للمكسرات. طيب نيجي بقى البيض. البيض is a good source لو اكلنا الفرخه بذره كتان. ومع الاسف الناس عندنا بتاخد ارخص حاجه، مش عايزين يرموا شويه بذر كتان جوه العلف. فالبيضه يبقى فيها تلت الاوميجا اللي المفروض، بينما الدول الاجنبيه هتلاقي البيض مكتوب عليه اوميجا انريتشد عشان يبقى فيه. البيضه الواحده هيبقى فيها تقريبا اكتر من ضعف كميه الاوميجا 3 زي ما انتم شايفين. يبقى اذا احنا دي مشكله عندنا واحنا قلنا لكم. الحلو بقى السالمون والماكريل، الحاجات الثانيه السورد فيش وبلو فوت دول بويزنس، يبقى دي من الحاجات اللي احنا نقدر ناخدها صح. طيب دي رسمه السمك اللي موجود في مصر. مشكله السمك في مصر خدوا بالكم، الاوميجا بيزيد لما امشي يمين والميركوري بيزيد لما امشي تحت. يعني اذا الحاجات الهاي اوميجا هم دول سالمون ماكريل هيرنج ساردين، مش دول اللي بناكلهم في مصر. احنا بناكل الحاجات اللي ما فيهمش، تيلابيا بولتي سولفيش موسى بلط بوري، كل الحاجات اللي احنا بناكلها اللي فيها لو اوميجا سمك. السمك اللي فيها لو كونتيننج في الاوميجا بتاعنا مع الاكل. يبقى احنا المفروض ندي لكل الناس، ولا الناس اللي هم بس ديفيشن، ولا الناس اللي عندهم حاجات تانية، ولا in pregnancy ولا in lactation. هناخد بالنا مع بعض. هو الريكومنديشن احنا بنتكلم pregnancy lactation بس. هيجي واحد يقول لي طب ما مش جايد لاينز. لا، الجايد لاينز تقول لك الناس should receive كذا، لكن مش بنقول we should supplement. فكل بلد تحدد الدايت بتاعها. احنا الدايت بتاعنا ما هياش كويس قوي، فاحنا البريجننسي مهم، لاكتيشن مهم. احنا مع الاسف الاطفال بتوعنا عندنا نسبه اعلى نسبه، احنا عندنا نسبه الاوبيستي في الاطفال 15%، نسبه المالنيوتريشن 20%، ونسبه الستانتنج 10%. يعني تخيل ان احنا عندنا تقزم لغايه دلوقتي، احنا سنه 2024 وبنتكلم ان احنا عندنا نسبه عاليه من التقزم. يبقى اذا كده، وزي ما قلنا ان احنا نصرف دروس قد كده مش كده. يبقى it's not a universal recommendation، لكن جرى على عرف عايزين 300 EPA 200 DHA، وده هنلاقي ان احسن لينا. اوكي؟ دي conclusions بتاعتنا. يبقى احنا supplementation كل دي حاجات ممكن ان احنا supplemented. الاوميجا من ضمن الحاجات اللي احنا بنحب نعمل supplementation. When should you start? Prenatal NIMNI stores is good. Antenatal visit first is good. First trimester is good. وvariable ملهاش لازمه الفاريابيليتي. هل ندي ولا لا؟ في بعض الحاجات في ناس مقتنعه، في ناس مش مقتنعه، في ناس بيبقى الهاير كلاس. احنا we are shifting ان معظم الناس بتاخد اوميجا. طب بالنسبه للسمك، ما نقول ان انا تاخد سمك كده. الفيش in our markets are low mercury fish بس they are low omega fish. يبقى السمك في مصر low mercury ولو اوميجا ايضا. طب بناخد اوميجا انريتشد ايجز ما عندناش في مصر، لكن لو عندنا. لكن تعرفوا في الكويت البيض العادي بدينار الطبق، البيض الاوميجا انريتشد ب4 دينار. يعني شوف بيزودوا 4 اضعاف لمجرد ان ده افيد في الاوميجا. In lactation it's better ان انا اكمل كل حاجه، الايرون والمالتي فيتامينز والكالسيوم والفيتامين دي والاوميجا يستحسن اكمله. اوكي؟ طيب نبص، احنا الشركه عندنا دي شركه انفينيتي. من الحلو فيهم عندنا الاوميجا 3 650 هيغطي كل ريكورنس اللي هو 200 350. هم زيودين فيتامين دي وفيتامين سي. معظم الاوميجا في السوق الانتي اوكسيدنت اللي بيحافظ عليه هو فيتامين اي، كويس؟ لكن هنا حاطين فيتامين دي اللي هيفيد، وفيتامين سي برضه هيفيد. الحاجه الثانيه عندنا انه بالجاميز. ليه؟ لان هم لما دخلوا السوق عملوا تارجتنج للاطفال. ما احنا عارفين مهم في البرين ديفلوبمنت، مش كده ولا لا؟ فابتدينا قلنا طب وليه الستات كمان؟ ويكوي ان انا لما بيجيبوا له عينات انا باكلها، لان اتس فيري نايس. لان احنا عندنا الاوميجا ليه افتر تيست ساعات، ولو اتكسر هيبقى مر جدا. وهم قدروا يعملوه في جامي بيرز، وان هم عندهم نوفل فورمز كتيره. اوكي؟ they are mercury free زي ما قلنا، عشان ما نحطش كده الفورمال. زي ما قلنا الفيتامين سي هيزيد نيورو ترانسميتر انتي اوكسيدنت ويحسن الايرون ابزوربشن. الفيتامين دي برضه مهم، رغم ان احنا بنقول 400 لكن احنا دلوقتي بنقول الفيتامين دي حتى لو زاد يبقى كويس. فلو بتاخد اكتر other vitamins مش هيبقى فيه مشكله خالص. دي كلها فوائد. Thank you very much. ميرسي خالص Mr. Chairman و thank you.